Okay, greetings everyone. I am online with Dodi Gauthier, and she is going to be helping us with Chapter 33, which is Obstetrics and Neonatal Care. Dodi, can you tell us a little bit about yourself?
Yes, I am best of all, a Green Bay Packers shareholder. And I'm a registered nurse who went to a diploma program, then got a bachelor's degree in nursing and a master's degree. And I was a clinical nurse for 41 years. I worked at Cottage Health for almost 30 years and spent 10 years delivering babies in Utah. So I've been an obstetrical nurse during that whole entire time, working in labor and delivery, antepartum, postpartum, and then also doing triage, working in the operating room, and taking care of newborns. So it's quite the process of being a labor and delivery nurse. I got involved through the emergency room with a nurse that was teaching medics about 10 years ago, and was really honored to be able to teach both paramedics and EMTs as their skill station, but also teaching with Justin at NCTI, and also doing a little bit of guest lecturing at UCSB with Brian Fernandez, and also doing, forget what we called them, skills days with the medics on a yearly basis.
And I think it's really important to bring up that the OB section for EMTs is one of the most difficult for students. And I think it's because the instructors are so scared of the concept of having babies. And I know that we've been having babies for millennia, and it happens and it's natural, but it's very uncomfortable for a provider who's used to coming in and finding someone with difficulty breathing or chest pain or things like that, to now have mom in labor and then deciding whether or not to either stay at the scene and have baby there, or to transport mom and baby off to the hospital. And I know you're going to talk about that, but I'm super glad to have you here, Dodi. It's always a pleasure, and I love our time together. So thank you so much for being here. I really appreciate it.
You bet. I know this is a low volume, high risk situation, and it really is the one that medics hate. Even after they've been involved in a few deliveries. I love delivering babies, but in the hospital, I had every resource available to me. And you have, 2 cord clamps and your knife that you all carry.
It's funny because the first time I ever delivered a baby was actually in the hospital. So I was an EMT on the ambulance, and responded over to the hospital to transport mom down to Cottage. We were at San Ynez, and as I walk into the hospital, I'm like 18 years old. I'm a brand new EMT, just like, what are we doing? This is gonna be so much fun, And the physician is walking around. There's just one physician in San Ynez, and he's walking around outside asking the nurses, like, where are the gloves? I need this, I need that. And I walk into the room and I'm like, hi, ma'am, my name's Justin, I'm an EMT. And she's like, ah! And there's no covering on her whatsoever. And I see crowning, and I was like, oh my gosh, this is happening right now. Like, I'm going to have to do something. So I did the football catch where just a little bit of pressure and just a little bit holding the baby, and baby just slid out of mom. And I have now just delivered my first baby. I walked into it.
The first baby I delivered, I was, we went from our labor room to a delivery room, and we were in the delivery room, and the woman had an epidural. She really didn't feel like pushing that much. The anesthesiologist had brought in her husband, and all of a sudden I saw the baby's head was really emerging. It was more than crowning, just from the contraction. And I had two physicians that were in the scrub room, and the water was running, and they were chatting, and they could not hear me. And I was like, it's like it happened yesterday. Dr. Johns, Steve, I need you. And they were like oblivious. And so the baby delivers into my arms, and I put the baby up on her abdomen, and the anesthesiologist walks in with her husband, and she's like, honey, Dodi and I had the baby together. Oh my word. When the doctors finally came in, they were like, what the heck happened? And I was like, dude, can you not see what happened? I know, it was really funny. We were bonded for life. That child is now like 44. So
it's so interesting, you know, to have those situations, and it's very heartwarming. And I'm sure you have plenty of heartwarmings. I know you have bad ones too, but to bring, you know, life into the world, it's not a scary thing. It's just, you know, it's something that you're going to go through, and you're going to be stronger for it. So don't be scared of this situation. Just know when is the appropriate time to stay and play, or when is the appropriate time to transport off to the hospital.
Absolutely.
All right.
Making sure that you're taking care of yourself as well, with as much personal protective equipment as you can have available. But know that the delivery is not sterile. The vagina is not sterile. The baby is not sterile.
Right.
So, but when you have preterm babies or complicated deliveries, you just want to make sure that you have as clean of equipment as possible. It makes me laugh that we sterilize everything, where germs are everywhere. So.
I know it.
We're a bunch of silly people.
All right. So what do we got going on for our slides?
Well, let's, go through these slides, and I think that the pictures that I've added will be of benefit to students. I also feel that it's important that you really read this information, because it's going to be really new for you, and there are different body, there's different anatomy and physiology in pregnancy as to anybody else. So if the changes in pregnancy happen to anyone else, they would be considered pathologic. So it's important to understand, as the uterus grows, that left uterine displacement or side-lying positions are essential for venous return. That's a really big thing to remember. Also, blood pressures vary depending upon what trimester pregnancies pregnant people are in, and that CPR is a little bit different in a pregnant woman too. And again, that left uterine displacement is really it's mandated in order to resuscitate someone.
Right.
So we're jumping ahead though, right? I like to think that most deliveries occur in a hospital or birth center. I will tell you that there is an increase in home births, and I know in Santa Barbara County there are quite a number of home births, and they are planned that way. I know that the home birth has increased since we have had the coronavirus. People are really afraid to go to the hospital. And some of those are planned, and some of those end up being ones that you may be called for. So occasionally that pregnant woman is unable to get to the hospital. So what Justin was saying is so important, that you need to figure out if you should stay or if you should go. And how safely can you transport a patient? So if we take a look at, we're going to hope that this works. One of the things that happens out there in the community, thinking about what obstetrics is all about. Stop. People get all worked up. They're so excited to talk.
Paramedics helping baby born in a car, huh?
Yes. Fire department, police department, medics.
Sounds like a story Mary and I had.
Exactly. You just never know, except you didn't have snow flurries like he does.
No, we don't. I just want to let you know that the audio is not working, but I'm sure you can tell us what's going on.
Oh, okay. So these people were on their way to the hospital, and they ended up pulling off the road into a bowling alley parking lot. And they really decided that instead of trying to go to the hospital, that they would pull over and call for assistance.
Right.
So, of course, who comes first? The fire department, followed by medics. So the dad pulled over, and the baby was born when the fire department got there. So
Gotcha.
the best thing about this story is your car is never going to be the same. You should sell it and get a new one.
Oh my gosh, so true.
Can you imagine? I know. Let's drive this car again. So
yeah. So just to talk about that call Mary and I had. I was an EMT. Mary was the paramedic, and we get called to an off ramp where we're supposed to meet a patient who's in labor, and they had just pulled over, and it was like probably 6 blocks above our station, so we're there very fast. And lady is in the passenger seat of the car, husband's driving, and she's already had her water break, and so you have mucus and fluids and everything. And take a quick look, just a quick look at how the baby was positioned, and look down, and baby has come out of mom's. Like when you move her shirt, like she's got baby and it's still right here. So put baby just on mom's chest, and I was like, hey, we got to stand you up. And she's like, I don't think I could walk. And I was like, yes, you can, and we stand her up, we help her, obviously, but like we put the gurney right next to her, we sit her down, we put chucks and everything. And we just grab her and we get her warm, we get baby warm, and we just transport both of them off the hospital. And the baby was so premature that we didn't do anything with the umbilical cord. We kept the umbilical cord connected, no cutting, nothing like that. And it retained a pulse that whole time. So we never worried about cutting it, especially because the baby was so little. If you recall, I think it was 25 weeks, 27?
No, I think it was 23 weeks.
23 weeks.
Very, very premature.
The island was still fused.
Right.
Right. So very, very little baby, but we just worked with that and transported off the hospital. And that kid is still alive today and has had multiple birthdays. And Mary is still very much in touch and in love with the family. So. That's
such a good story. It impacted an awfully lot of people. And that's another thing that's so important to remember is the newborn really needs warmth. If you can imagine yourself coming from a swimming pool into an air-conditioned room, that's how they're feeling. So drying them and keeping them warm is essential. So we'll talk a little bit more about that later too, but the best way to keep a baby warm, if it does not require resuscitation, is skin to skin with the mom and then covering them both. And that's essentially what we do in the hospital as well. So anatomy and physiology, one of the things that I loved teaching about when I taught this class live, it was so much fun, was to see how many times we could say vagina during the class. It seems to be like the word that no one ever wants to say. And it's silly because it's an important part of anatomy. And so if you learn the correct terminology for your body parts, vagina would be something that you would use. So don't be afraid to use it. Also, one of the best quotes I've ever heard is if the uterus is a very powerful organ. If men had one, they would brag about it. So it's important. It is a very important organ, and it houses a fetus for 280 days. So that is extraordinary to me. I think everything about labor and delivery is extraordinary. So you can't spend, almost half a century working with pregnant people and not feel that way. Ovaries are also super important. Part of they release the eggs to become fertilized by the sperm. So it's really important that you understand where those ovaries are as well, especially when it comes to ectopic pregnancies, since they are the most likely place for an ectopic pregnancy to occur. Ectopic simply means outside of the uterus. It doesn't mean that it happens in the fallopian tube. It means that it's not within the uterus. So lots of follicles, and each of those follicles contain an egg. A female fetus has about 400,000 eggs that she is born with.
Wow.
And she uses, X number of them, not many, throughout her lifetime. So you can understand that they get old. Where men make sperm new all the time for many, many decades. So it's just interesting how our bodies are put together. I think it's important from looking at this slide to understand how the uterus is kind of flexed forward. And when we talk more about trauma, I think that's really important too. The uterus will stand up straighter once it has a fetus growing inside of it. But the uterus is composed of 3 parts. So we have the top of it, and the bottom of it is actually different material. That's called the cervix. So in the middle part, with the top is the fundus, the middle part is the body. If we don't know what to call something, I guess we call it the body. And the fundus comes into play once the placenta delivers, and we'll talk about that as well. The cervix is the part that opens in order to allow the baby to come out of the uterus. So.
And when you're in the hospital and they're checking dilation, they're checking the dilation of that cervix.
Exactly. Yes.
Not so something that EMTs have to worry about, but just so that they're aware.
Exactly. Keep your hands out of the vagina. That's an important rule for anybody. And we in the hospital will check the dilation of the cervix when we feel like people are not making progress in labor, they want pain medication, or it's time for them to push. So, but you'll know when it's time for them to push because they'll make noise like they're pushing. So, and it's really important that you pay attention to what a mom says. Really, the women know what's happening with their bodies. So if they're saying the baby's coming, it's really important that you take that's the time to look and say, oh, I see that's true. I better have my personal protective equipment on.
Because it gets messy.
Oh my gosh. Both of my important people here in Wisconsin, my sister and my niece, are teachers, and they think that it's crazy that I like body fluids so much. So they are disgusted by body fluids. So it's a good thing they're teachers and not nurses. So they don't even want me to talk about any body fluids anytime. So I have to find people like Justin to talk about body fluids.
Bring it on.
The only one I don't like is mucus, so I'll leave that to the respiratory therapist. So the fallopian tubes, there's 2 of those. They extend out from the uterus. I always joke about how the uterus and the tubes look like the Texas Longhorn sign that there is. So if you remember that is what the reproductive organs look like. The fertilization, usually what happens is the sperm go up through the uterus, they go through the fallopian tubes, the egg is released, and somewhere in about the top upper third of the fallopian tube is where conception occurs. And that the ova then goes down to the tube into the uterus where it implants in the lining. And then that's where the growth occurs and where the placenta is developed. So, and that's why you can see that sometimes the fertilization takes place, the egg and the ova doesn't move. And so then the pregnancy begins in the fallopian tube. And really, it can't last too long. As you can see, those fallopian tubes are not very wide. So it certainly couldn't accommodate a very large baby.
So a female can get pregnant, have it implants in the fallopian tube, and then within a few weeks is going to start running into problems. And that's when we look at ectopic pregnancies possibly causing like a significant amount of bleeding.
Right, so that tube can rupture. It can cause significant pain. It will cause, one of the things that you want to look for is subscapular pain. So not just gallbladders, but also an ectopic pregnancy. That's
subscapular, so into the back.
Yes, absolutely.
Is it associated with the side, or is it just kind of on both sides?
No, on the side that the ectopic, where the ruptured tube has been.
The referred pain, possibly subscapular.
Mm-hmm. Yep. So the uterus then is very small. Actually, it's a small organ. It just has a capacity to grow very, very large. So it protects the fetus. It also provides a contraction so that the baby can be born. And also the vagina, or the birth canal, is the vagina and the cervix. And as I said before, it really is a different kind of material. The cervix is a collagen versus a different kind of muscle. So just interesting the way that our bodies are formed. So sideline view with the fetus, generally speaking, what happens is the placenta, which is an essential organ, only occurs in pregnancy. So it's a fetal organ and a maternal organ. Generally, it's in the fundus, or the top part of the uterus, but not always. It can actually be in this area here in the front, called an anterior placenta. And it can also be over the cervix, so that you would have a placenta previa meaning before. And that can cause a tremendous amount of bleeding. So when we talk about reasons for vaginal bleeding, we talk more about a placenta previa and also a placenta abruption. It's a big difference between the two of those.
And that that placenta previa would be spotted on pretty much any OB exam prior to birth, I'm assuming. So you would be able to spot where that fundus, where the placenta has implanted.
With an ultrasound.
With an ultrasound. So as long as you have prenatal care, it's a good possibility that you already know that you have a placenta previa. Yes. And for that situation, you're going to be a higher risk patient, and then you're probably going to have a C-section, I assume.
Yes. A placenta can't be delivered first. The first bleed with the placenta previa is actually pretty significant. So that might be, and a lot of people have a previa in early pregnancy. So it could be definitely a reason why people call for vaginal bleeding is because they have a previa. Now, people that have prenatal care and have any risk factors often will have many ultrasounds. And there's bleeding for a variety of reasons in early pregnancy, only one of them being a previa. So, and they have subsequent ultrasounds, because sometimes that previa it sounds so silly, but sometimes the placenta moves. And it's really not the placenta moving as much as the uterus. As it grows bigger, the placenta just moves along with it, so it's no longer covering the cervix.
Yeah, as the placenta enlarges, right? Or
yeah, not, it sounds so funny. The placenta moves. It's really the uterus growing.
Right.
So the vagina, the passageway from the uterus, it's about 7 to 8 inches long. It's very it's able to stretch a lot, as you can imagine, pushing a baby through it. So it's made out of, there's a lot of rugae in it. So it's a little bit convoluted, but it's so important to understand how much it can stretch and then go back to a normal size. The breast's also a big part of the anatomy and physiology. They develop ducts during pregnancy. Colostrum is the first milk that is excreted from the breast, often occurs in the last month of pregnancy. So someone may say that they have discharge from their nipples, but the ducts are so significant in the blood supply to the uterus. One of the first positive signs of pregnancy actually might be breast tenderness as they grow. So, but also very important part of the reproductive system. And then my favorite thing of the products of conception is the placenta. I think the placenta is the coolest thing ever imagined. It is, again, as I said earlier, it's a fetal organ and a maternal organ. It attaches to the uterine wall, and it's a workhorse. It does everything. It's the respiratory system for the fetus. It's the kidney and removal of, sorry, sometimes my brain just goes completely blank. So sometimes I let people fill in the blank, and sometimes I just hem and haw around like I am now until I come up with the.
Well, it's funny to me because I think that the placenta is the worst part of pregnancy. Because no, this is me though. I hear what you're saying. I just think it's the worst part because when the placenta delivers, it's this alien deflated football that's super slimy, and I'm sorry that I don't respect it.
It's slimy, everything is slimy. But think of what it does.
I know. It's amazing.
It waste products away. It's a respiratory system. Amniotic fluid, it makes amniotic fluid so baby can float in that. So it can stay at a spa-like temperature and have a spa-like environment. It's crazy to me that something so small that weighs 1 lousy pound can have so many job descriptions.
Yeah, it's
kind of like a parent.
Totally.
It's pretty fabulous. So of course I have to have thousands of pictures of it. So the separated circulations, it's important to understand that they do allow substances to pass. It's not a complete, it's a sieve. So there are things that absolutely can pass through it. And that's why we have issues with substance abuse. So anything that's ingested by a pregnant woman really has the potential to affect the fetus. So medications, illegal substances, alcohol, as well as appropriate nutrition. So, but
this is an interesting image as well, Dodi, because in human body, for adults and kids and for everything that we've taught so far, the only artery that is deoxygenated is our pulmonary artery, and the only vein that's oxygenated is our pulmonary vein. But in pregnancy, we have the same thing happening inside of that umbilical cord, right?
Right. I love that. That's the only other place that the umbilical vein here does carry the oxygenated blood, and the artery carries the deoxygenated blood. So it's fascinating that the only other place is pulmonary. Yeah. This, you can see how the placenta looks like a tree. The branches kind of going out. Generally speaking, the cord implants near the center of the placenta. This looks more like a marginal insertion, which I didn't even notice when I first put this up. That's so funny. It might be the way the placenta is lying, but most of the time it's from the center. On the top, you can see this is the membrane as that has to rupture in order for the baby to be born, so that the baby lies in that bag of water. And what you're looking at is actually the fetal side of the placenta. It's much prettier. The other side looks like liver. It's raw liver. It's ugly. The maternal side that's attached to the wall of the uterus. So the baby gets to look at a prettier view. Although many people don't believe it's pretty at all. But so here's a good picture of both the umbilical vein, the umbilical artery, and how it's covered by Wharton's jelly. I'm sure Dr. Wharton was the person that was elected to have his name after that gelatinous substance around those vessels. Some of the umbilical cords have a lot of Wharton's jelly, and it's hard to put a cord clamp on them. And others have very little, like this one. So, but it protects those vessels. So it has a very important role. It also has no nerve endings, which I think is very interesting. So it doesn't hurt when you clamp the cord. It doesn't hurt anyone because there are no nerve endings.
Still feels weird when I poke my belly button though.
Well, yes, I understand that. So just don't poke it. So the amniotic sac is fluid filled. It has between 500 and 1,000 mils of amniotic fluid, depending on what part of the gestation that the pregnancy is. Towards the end of pregnancy, there's a little bit less as the placenta decides that it doesn't really need to make any more fluid. The placenta really likes to be done at about 36 weeks. So why it's a workhorse for 260 days or so, it really says at the end of the pregnancy, I'm over it. So, and that's why we as providers really don't like women to go too far over their due date, because there's less amniotic fluid. And less amniotic fluid means a baby probably is moving less, because the amniotic fluid supports fetal activity and fetal growth. So it's just something interesting. The women that rupture their membranes, though, especially in the field, you would think that there was 10,000 gallons of fluid, because it just keeps coming. People would come to triage and they'd say, my water broke, and it just keeps coming. Why doesn't it stop? Why isn't there, is it not done? And it actually is replaced every 24 hours as well. So the placenta will just keep manufacturing it.
Wow.
So the amniotic sac actually is two layers. It's the amnion and the chorion. So therefore we have the amniotic fluid. So just everything about it is fascinating.
And the amniotic fluid, that is also, not only does it allow the baby to move around and stretch and float in a temperature controlled environment, but it also reduces that trauma forces that mom may ensue, right? So if mom bumps into something or falls down, that water is going to help protect the unborn baby.
Yeah, it's a good shock absorber.
Totally.
So, and so is her abdominal muscle. So is that strong, thick muscle of the uterus. So all of that is really helpful for anytime her abdomen gets bumped or if falls.
Right. I know that we haven't talked about trauma yet, but just to bring it up, when mom has baby, and let's say she's got significant gestation, where she's above the McDonald's sign, so greater than 20 weeks, I believe, is the book answer.
At the belly button.
Right.
Yeah.
The uterus above the belly button. And that's when we're really concerned about car seatbelts and getting the seatbelt below this, because we don't want that force transmitted across the amniotic sac. We don't want that force to go into baby. So getting that seatbelt low enough under the belly is really important.
And I really think that it's our job to make sure people wear their seatbelt correctly and have a really good picture of that that's coming up. Because as public servants, I think it's just important that we remind people how to be safe, and wearing a seatbelt is a really important part of that. So normal changes in pregnancy, like I alluded to earlier, sometimes I even have big words I can use. It's so great. But all body systems in pregnancy will undergo changes. The respiratory changes are actually often driven by hormones, because hormones is all about pregnancy, I'm telling you. And I will not tell the joke. So.
I was just worried about it. I was like, oh no, here we go.
But yeah, there's so many hormone changes in pregnancy, and the respiratory changes, there is this drive to breathe. Progesterone does that. So progesterone means for the pregnancy. So it keeps the uterus calm during pregnancy, but it also makes women have a drive to breathe. So they are kind of short of breath, and especially as the uterus grows larger and larger and impinges on the diaphragm. Women actually get a barrel chest in pregnancy. So their breast size doesn't just change, but their chest size changes as well. They actually have sometimes rib pain as the uterus grows. And it's so confusing for them. You know, it's like, I've never had rib pain before, but because their chest has to expand so much to accommodate the uterus, plus the size of the organs, the heart actually grows sort of like this niches. You know how his heart grows 10 times its size. The same is true in pregnancy. It also has to grow larger because there's an increase in blood volume. So cardiovascular changes, the heart rate increases in pregnancy, the cardiac output, the amount of blood that mom has increases by 30 to 50%. So her stroke volume increases, and that's the amount of blood that's pumped from her left ventricle. So she has more blood. She has increase in her heart rate because she has more blood. She's pushing out more blood into her system, but she also is anemic. That blood volume increases, mostly plasma. So it's 70% increase in plasma and a 30% increase in cellular volume. So she has physiologic anemia. So almost all pregnant women are anemic. So we encourage them with prenatal vitamins that have extra iron in them to really build that up. And the reason they have such an increase in volume is because they have so much more tissue, plus the fetus, that they need to oxygenate. And they also they lose about 500 mils at delivery. That's the expected amount. It's never what's documented in a delivery record, but I mean, that is the expected amount, and that's what she's building up for. She's also more likely to clot. She has a higher increase in her clotting products, including fibrinogen. So she can clot a lot easier. And again, that's purposefully so that she can stop bleeding after she delivers. Musculoskeletal changes are quite significant as well, with relaxin, another hormone that really, especially in the third trimester of pregnancy, when she has changes in her pelvis, balance changes as her center of gravity really changes, that she's much more likely for having balance issues and falling. So that's an important thing to remember too, that women just have to be a little more cognizant of the fact that their balance has changed.
And they also the pubic symphysis at the front of the pelvis. It's loose. It's bound by. It does move. So it's cartilage together, and then as that loosens, it allows the two sides of the pelvis to move slightly, so that can cause her to easily kind of rock over to one side.
Plus, that center of balance too. The bigger that your belly is, and the more lordosis you have, where the kind of a S-shaped curve to your back, as your belly gets bigger. So all those things just are really predispose women to being more likely to fall. Hormonal changes, lots of those. I think we've said enough about hormones. And then also skin, the skin changes. There's a mask of pregnancy that people may see with a discoloration of their face. The skin, the stretch marks that happen as the skin changes with, gaining 25 to 30 pounds during the pregnancy. So depending upon where women start at the beginning of their pregnancy kind of helps dictate the recommendation of how much weight they should gain. But some people's skin just doesn't stretch very well. And so those stretch marks are often a reminder of a pregnancy. And also the linea nigra, which is the line that goes from the umbilicus to the pubic bone. There's often a brown line that occurs there that does fade after pregnancy, but that is just something that's normal in pregnancy. Oh, here's the hormones again. They are, really important for fetal development, but also for preparing for childbirth. So progesterone and the changes that there is in it as people get closer to the time for them to be laboring. And the uterus also shifts from its normal position. That has nothing to do with hormones, but just anatomically. And also the ureters can be impinged in the pelvis. So women are much more likely to develop a urinary tract infection that can then become a systemic problem because it's a renal infection. So there's a lot of changes that go on. If you have so much more blood volume, your kidneys are getting more blood volume as well. They're filtering more. But also urine might sit in the bladder for longer periods of time. And so women are also predisposed to having urinary tract infections during pregnancy. So it's really important that she empties her bladder. Pregnant women will say to you, empty my bladder. Of course I empty my bladder. I go to the bathroom like 10,000 times a day. I like to joke about following pregnant people around in public places because they always know where the restrooms are. So I used to, when I worked in Salt Lake, there's so many pregnant people there. We'd go to the zoo and I'd be like, look at all the pregnant people. We'll know where the bathrooms are. So, but that really is, it's important for them to keep their bladder empty and to keep hydrated to prevent them from getting a urinary tract infection. Let's see, respiratory capacity, as we talked about how that changes, blood volume, the speed of clotting increases, cardiac outputs increase. So and really what's important to understand about the cardiac output is, again, if you have to do CPR on a pregnant woman, in order to maintain her cardiac output, you have to have left uterine displacement, and that's manual displacement, in order to get venous return. So, and I'll show you a picture of that too, so you'll understand what the heck is she talking about. Really you're pushing the uterus off the vena cava, and that is someone's job, an additional person that you need in order to do adequate CPR. The return in CPR, the cardiac output, what are you getting from venous return is so little in a not pregnant person. So You have to be able to maintain that in a pregnant person. Isn't it like 10% or something like that? It's
the efficacy of our best CPR is about 30% what the heart does.
Yeah, so it's really important to do so. Increase in vomiting, first trimester is morning sickness. Third trimester, I think part of it has to do with the fact that your stomach is so small because your diaphragm and your uterus are pushing up and really making the stomach smaller. You have, again, from hormones, you have a acid reflux. So there's relaxation of the pyloric sphincter. So it's much more likely for women to aspirate when they vomit. So that's really important. Another reason not to have them lying flat on their backs, at least have some of their heads elevated if possible. But that is a very real issue that can occur. And then again, I don't know how many times we can say we need to support the fetus with the increased workload of the mom's heart as well. So weight gain, I talked about how this is, it's important that we see between 25 and 30 pounds of weight that's gained. A lot of that, the placenta, the fetus, the amniotic fluid, the size of the uterus, just the additional volume of blood, and also edema. Pregnant women are much more likely because of hormones, and also dependent edema. So it's important that she put her legs up at the end of the day too, as much as possible in order to prevent that edema. The joints, all the joints are looser, but the pelvis is what we are so more concerned about as far as falling and imbalance. It is advantageous though to have those joints become looser because it makes a little more room for the fetus in order to be born. So that's quite friendly. And then again, I don't know how many times we're going to say If you don't know the body center of gravity is changing by now, shame on you, right?
Right.
So that's right.
As far as like an EMT assessment of a pregnant female, that's going to be a normal finding for us, most likely in later pregnancy, where we notice that edema. We're going to notice that dependent edema in the feet. She might complain that she's increased in shoe sizes. When you look at her fingers and you're looking at rings, they're going to be tighter, and that's going to be a normal finding.
Yeah, the hands really get a lot fatter too. They get so swollen. And I think people sometimes think that then, oh, I should stop drinking. And really, you need more water in order to get rid of that swelling. So it's just a public service announcement for pregnant people, just to reiterate that. Right. So one of the things that has always been in the protocols for medics is providing oxygen for people when they have trauma makes sense, but when they have a call. So not all pregnant women require oxygen. I think it's really important to remember, look at O2 sats. If oxygen sats are above 95, then you are good in a pregnant person. Do you use something lower than that, Justin, in a non-pregnant person?
94 and above. We just follow
okay.
guidelines.
Okay. And you can keep that in mind, then go ahead and give them the oxygen. But oxygen can pose problems for the fetus if it's given for long periods of time. So for an assessment, for an emergency call, for transport, I don't think that this is a problem at all. But it is for long-term that we would give moms, for instance, in labor. We used to give women oxygen for long periods of time for a variety of reasons, and it was really found that it could be harmful to the fetus as well as to her. So, but for a transport, use your protocols. And I just like to reiterate too about using common sense. Use your protocols, use critical thinking, and ask why am I doing this? Because I think that will help guide you to making the right decision. So diabetes is common in our country, but it also can happen during pregnancy because women actually have a carbohydrate intolerance during pregnancy, which is normal. Most women actually can adapt to that, but if not, then we have what's called gestational diabetes. So these women actually are best treated, first of all, with diet and exercise. If that doesn't work, some physicians will provide them with glucophage or metformin. And if they have been using those previous to pregnancy, they may stay on that. But most people are using insulin. So it might just be for the pregnancy, but gestational diabetes may turn into type 2 diabetes. So if you look at what our population is of people who have diabetes, it's often those people with hypertension and are obese. And if we can treat those things, then the type 2 diabetes often goes away. So the same is true, but knowing that gestational diabetes will predispose this woman to developing type 2 diabetes is an important thing. Just to keep in the back of your head, it's not going to be something that you need to worry about as far as transporting. If a woman tells you she has gestational diabetes, then you can ask her about her blood sugars and when she last did them, and what the results of those were, depending upon the reason for her transport. Hypertensive disorders, this is my favorite thing about pregnancy, other than the placenta, is preeclampsia. I think it is fascinating. Its pathophysiology is really remarkable, but it is a fairly common complication, especially in those women who have had hypertension or who have hypertension currently. Pregnancy-induced hypertension is an outdated term, as toxemia is, but you will hear those phrases. So, but preeclampsia is part of the hypertensive disorders of pregnancy kind of triad. So generally we see symptoms of preeclampsia after the 20th week of gestation. And they are hypertension, a persistent headache that's often occurs in the occiput or the back of the head, visual abnormalities. So you ask about a loss of vision, a loss of peripheral vision, or spots before the eyes, swelling in the hands and feet that are more than what she has normally complained of. Anxiety, it can put anxiety on anything, I swear. But the thing about preeclampsia is it was thought to happen after 20 weeks, but it actually is something that occurs at conception. We just don't normally see symptoms until the 20th week or halfway through pregnancy. Remember, pregnancy is about 40 weeks of gestation. It really isn't 9 months. I don't know why they ever told us that. It's just tricky. It's 10 lunar months, 9.5 weeks. People hate this when I tell them this because they're like, oh my God, you're adding to my pregnancy? Because they're already thinking that it's such a long time. And then my comeback to that really is, well, thank God you're not an elephant, because their gestational age is 24 months.
Oh my gosh.
But they have a lot bigger of babies. Our gestation is only 40 weeks because otherwise the babies would be too big to deliver. So I find that so interesting too. And if you think our babies don't just get up and walk after they deliver, it takes them a year to learn how to walk. Their head size would be too big to be delivered. I can't even imagine delivering a 2-year-old, you know. It's just like our babies are big enough to begin with. So, but preeclampsia is something that's fairly common, and it requires treatment with magnesium sulfate. And it's not actually a very small dose. We use quite a big dose in the hospital of giving them a 4-gram loading dose over 20 minutes. So, and they don't feel really great when we give it, but we give it in order to prevent them from having an eclamptic seizure. So your protocol will tell you something different than that, and that's okay. We start loading them up as appropriate, because if they have an eclamptic seizure, they are at risk for having issues with the placenta and abruption. And they can also have an issue with not oxygenating the fetus well, because you know what happens when you have a seizure is you are apt to breathing. Yeah. But eclamptic, you want to make sure you lay the patient on their left side. The left is always better than the right, but if the right side works for you, then go for it. You're still getting pressure off of the vena cava. You know, I like to joke about why people are always transported on their left side in an ambulance. And Justin, answer that question. Why do you transport someone on their left side?
So with a van-style ambulance, you have a wall on your right-hand side. So if you put a patient on their right lateral recumbent, they're staring at the wall. So they're looking at all this medical equipment. And just like Dodi's saying, left lateral is the best way to go. The inferior vena cava is more on the right-hand side. So the left side gets more of that pressure off. So just remember that anytime you're transporting somebody who's obviously pregnant, you're going to put them left lateral recumbent or on their left side to get that baby and the weight of that uterus off of the inferior vena cava. And I'm sure you're going to talk about it, but I just want to say it again, because this is such an EMT related question. There's a syndrome called supine hypotension syndrome. And that's where the weight of baby and the uterus are pushing down on the inferior vena cava, and that's limiting your blood supply coming back to your right atrium. So if the right atrium doesn't get blood back from the inferior vena cava, and it's only getting it from the head, it's going to drop your blood pressure really fast. So when you find a patient who is pale, sweaty, short of breath, and they look horrible, and they're laying on their back, and they're obviously pregnant, the first thing you should do is put them on their left-hand side. And obviously this is, you know, no signs of trauma, things like that, but get that pressure off the inferior vena cava, and you're going to watch those skin signs come back to normal.
Absolutely. So, and the other thing with eclampsia is maintaining a patent airway. allow them to have the seizure, and then insert an oral airway as necessary. A eclamptic seizure looks like any other type of seizure. It is short-lived for the most part. Generally, these women will not have a status epileptic. It's really hard for me to say that word.
Status epilepticus.
Thank you. But they might have another seizure if they're not treated with the magnesium. So it's important to transport them soon. Whew.
Yep.
Oh, look, and here's the picture. So we want to prevent that supine hypotensive syndrome. So here just is a picture of how those vessels are wide open when you have someone in left lateral, as opposed to being flat on their back. I think, we put people flat on their backs because we want to interact with them. We want to see as much of them as we can. And I think that we're just doing them a disservice by having them lay flat. So have them lay flat to do what you need to do, but then assist them to their side. I know one of the things that happens when we do cervical exams in the hospital is people always want to be on their backs. And I think it's like, you can't do anything unless I change my position and I'm on my back. And that's really not true at all. So I also will tell you, I prefer that you do a sideline delivery if you're going to do a delivery in the field, rather than having her lay on her back. And it's for this reason. You want to give the fetus as much oxygen as possible, as well as the mom. So here's a picture of what happens in an ectopic pregnancy. So bleeding in pregnancy, one of the biggest reasons is ectopic. So that embryo is the first 8 weeks of pregnancy. The fetus becomes a fetus at 8 weeks. I wish I was one of those people at the table that got to make all these decisions and make up all these big words. I think they're just so great. But this can cause, as we said before, the uterus to rupture and then cause internal bleeding. So there's lots of places where an ectopic pregnancy can occur. You won't know that by assessing someone. The most likely place is in the tube. It can also be in the fimbria, which are those finger-like projections that are from the tube and the ovary, and they are really like finger-like. They say, come to me, to the ova. Yes, but that is just another place that can occur as well. If women have uterine scars from cesarean or hysterotomy or any other fibroidectomy, anything in the uterus, it's a more likely place for there to be scar tissue, and there can be a problem with the placenta adhering there, as well as an ectopic pregnancy. So her medical history can be a benefit to you as well. So generally speaking, what happens with an ectopic pregnancy is women will complain of abdominal pain. They may or may not have bleeding. They can have uterine tenderness. They can have tenderness in their left or right lower quadrants. And then they have that referred scapular pain. So I think those are just things to keep in mind, and that when women report these things, it may be an ectopic pregnancy.
How much bleeding is normal, Dodi, for someone who is, let's say, in their first trimester, and I get called a lot for someone who has scant or a little bit of bleeding noted. Like, is that normal? Because do they need to go to the hospital? Like, what's advice? Obviously, I'm not saying like, yes, you should not go to the hospital. Yes, you should go to the hospital. But how common is that? And then what is the usual cause?
There's a lot of reasons why women bleed in first trimester, early second trimester. Sometimes women bleed during the time that they would have a menses in their first trimester. Some of them have issues with the placenta and the implantation of the placenta. So there could be a hemangioma kind of thing. So there's so many reasons that could occur, but having old brownish discharge is sometimes normal. I think she needs to call her provider regardless. And
Right.
oftentimes they will be triaged just to make sure there's no bright red bleeding. What we like to tell people is if you have bright red bleeding like a period, so that's a substantial amount of blood, then that it's important to come in to triage. Now, in first trimester, probably wouldn't have someone, they might come to the physician's office because it can also indicate a miscarriage.
Right.
Or in medical terms, that's called an abortion. So, and I know that abortion is kind of one of those words that's so loaded, sort of like vagina, but in a different way. And so I don't want people to feel like they can't use that word. When I talk to patients, I call them miscarriages. And then I also will ask if they've had a medical or a therapeutic abortion, because that also is part of their medical history. And we'll talk a little bit more about that when we talk about gravity and purity. It's hard to separate all these things out, you know, and try to give you some background about the world of obstetrics instead of, you know, 2 chapters in a book. So, you know, it's taken me 42 years to learn all of this stuff. And with the job that I currently have, I'm always looking stuff up, especially from the first trimester, because that was never my thing. I was the 3rd trimester person, you know, so continuing to learn. Also, the spontaneous abortion or miscarriage, abruption. So that is when the placenta separates from the wall of the uterus. So the most likely reason for abruption to occur is trauma. So it could be from a fall, it could be from domestic violence, it could be from the steering wheel of a car, it could be from a fall in the shower, it could be from a fall down the stairs. So that, you know, a lot of the most popular reasons for an abruption are from trauma, but they can also spontaneously occur. And I don't know why that is. It can also occur in labor. There could be a lot of amniotic fluid called polyhydramnios, lots of water. And with that sudden collapse of the uterus, the placenta can also erupt. So it's not there's not a significant number of them, but it's a significant reason why there's bleeding, especially in the 3rd trimester. Then the placenta previa, the placenta develops actually over and covers the cervix. So the placenta is always looking for the healthiest tissue to implant on. And if there's a multiple scars of the uterus from multiple DNCs or from cesareans or other surgeries, the placenta is like, oh gosh, there's no good place for me to hang out here. So then what happens is they go to the cervix, which generally is, well, it has a good blood supply and it allows it to grow there. So here's the previa versus abruption. So with a normal placenta on the left side, implanted again, generally in the fundus, the placenta abruption, the placenta pulls away from the wall of the uterus, blood can collect behind it, so more of the placenta can be pulled apart, pulled away from the wall of the uterus. So you also may have bleeding or you may not have bleeding. So it's concealed or revealed. The concealed bleeding to me is the one that's more concerning. The uterus and the abdomen just expands. It gets distended with blood. It gets really hard. And what we call it is it's board-like. You can't, it's so tense that you can't push down on it at all. And there's often a significant amount of pain associated with it. With the placenta previa, and often in abruption, the blood is kind of a port wine color, so it's darker. I like to say it's more like a Cabernet, whereas with the placenta previa, the blood is a bit, it looks more like bright red blood, and it's generally painless bleeding, but she also will have contractions that come and go. So an abruption, one sustained contraction, board-like tenderness, board-like uterus, painful, previa, bright red bleeding, painless, contractions that come and go.
And
So
with that abruption, are you developing any bruising right away? Like, do we ever see like
that's a good question. No, there's nothing on the outside that you can see.
it's that rigidity and the tenderness?
Yeah, yeah. So, and here's the concealed and revealed. So you can see on the left-hand side that there is bleeding. It's usually more bleeding than just drips, but and the concealed hemorrhage causes more of the placenta to be pulled apart away from the wall of the uterus. So to me, the concealed hemorrhage is much more concerning than the revealed hemorrhage. Then abortion or miscarriage, by definition, miscarriage is a preterm birth that happens after 20 weeks of gestation. So halfway through the pregnancy, it can be spontaneous, or induced, or medical, or I don't know why they call them therapeutic, but a choice that a woman makes to have an abortion. Most serious complications with these are bleeding and infection. So if a woman has a miscarriage, not all the products of conception come out. She's much more likely to have a hemorrhage and then an infection, or an infection and then a hemorrhage. So it's hard to clot when you are infected. So what's important is to treat for shock and then to transport these women as soon as possible to the hospital. Then abuse, women that are pregnant have an increased chance of being victims of domestic violence, and that will increase their chance of a spontaneous abortion or miscarriage. Oftentimes that abdominal punching, hitting is aimed at trying to have a woman have a miscarriage, a preterm delivery, or low birth weight. And that low birth weight might be because of stress and feeling anxious and not eating appropriately, from being controlled. It's very interesting, since I retired from clinical practice, I now volunteer at a domestic abuse shelter here in Wisconsin. And it's very interesting to hear the stories of these women, and really basically what it is all about power and control. So this is the domestic abuse circle of violence. And I think that it's so helpful to understand that it's not just physical abuse that can occur, but emotional, like bullying. Bullying is a sign of power and control, and what it is one type of abuse. Isolation, so not allowing someone to visit with their family or their friends, always having to have tabs on someone so that they know where they are at every moment. Minimizing, blaming, shaming, so telling someone to zip it, not listening to them and paying attention. Using their kids for guilt. Male privilege is another thing as well. Master of the castle. That's such an interesting phrase that we've used for a long time. Economic abuse, so that someone doesn't have their own money, or they're not allowed to have a job, and these are often things you have no idea are occurring. I've been surprised actually in my old age of hearing these stories that boil down to power and control. But, I had a job, but I had to quit because I always had to call in sick. Or I got fired, or, it's so interesting to really take a look at this. So this is really beyond the scope of what this chapter is all about, but I really encourage you to really do a little more research on what domestic violence is all about, because I think we don't do a good job of asking about it and assessing about it. And if you think about when you see a provider, do they ask you, do you feel safe at home? Is there someone in your life that is emotionally or physically hurting you? I don't think we go into depth very well with those. And I think that's one of the things I've always wanted to do a better job on, because it's a reason for a lot of things that we see as complications in pregnancy.
I know you and I have talked about this a lot, where this is a very underreported
Yes.
part. And we know it's underreported because this woman is going through so many changes already, and now she's got, you know, drama over here with her significant other or family or whoever it is, and it's all of this drama is kind of crescendoing around the pregnancy. So your likelihood of running into physical violence is much higher when you're pregnant. And I know that, once again, data is very skewed because it's a very underreported thing, but this is when females get hurt, is when they're pregnant. And that's something that us as providers need to ask about. Do you feel safe? Is there any problems? Do you need to talk to anyone?
And so part of that also, just to add on to that, is to make sure that you are in a place that is private. Because one of the things that should alert you and be a red flag is when a partner doesn't let you be alone with their
they're up in the situation.
They're in your face and in your space. So one of the things I learned to do in the hospital is when I do a physical assessment on a patient, I've asked the entire family to leave, and I go get coffee, go for a walk, and that, again, if people don't want to leave, oftentimes she'll say, "Oh, my husband can stay," and I'm like, I'm going to ask you really private questions, and I'd rather we did this privately. And if I can't, I had no qualm of going into the bathroom with her to ask her about things.
Right.
You're never, once you get pregnant, you're never alone in the bathroom again for the rest of your life. So may as well start in labor, right? That's right. So substance abuse, only thing really I want to say about this is there is certainly a higher incidence of substance abuse. There are many babies that are born addicted. They can be premature. They can have low birth weight. They can have issues with respiratory distress because of those two things, or because they are, because of their addiction, they are now in withdrawal. And those we know can cause respiratory distress. Fetal alcohol syndrome is a whole separate syndrome that it's many things that are included in this syndrome. And those are those infants born to those women who have abused alcohol. So I did not see very much of that in my career, a few of them, but certainly the addiction to, if we think about drugs that people are using currently, methamphetamines, ecstasy, and there's other things certainly that have made their way out that you are much more coherent about than I am. But just know that there's an increase in this. Your job is to make sure if you're delivering these babies is to get them to the hospital as soon as possible, in the safest manner possible. And again, paying more attention to your own safety as well. So what you see with addicted people, with cocaine, meth, ecstasy, I said those are really the kind of primary drugs that cause maternal tachycardia. They can cause seizures, and they can cause cardiac and respiratory arrest. When we have those, that is absolutely problematic for the newborn. And the newborn will most likely need immediate resuscitation as well, or very soon after delivery. So, okay, we're finally at trauma. So I think what's really important is not just in trauma, but any of the calls that you get with someone who's pregnant, is that you always have at least two patients. So you have the woman and then you have her fetus. She might have more than one fetus as well. So there actually is a significant number of women who have twin gestations. You can also see triplets and quads, although I think we tend to see less of them as we've gotten better with infertility drugs and artificial reproductive therapies. So, but they're ask people, how many babies do you have? Now, if they have not had any prenatal care, they won't know if they only have one fetus. They'll probably look at you like, what? What do you mean? How many babies do I have? So we don't have too many people that are Octomom that are having litters of babies. So that's fortunate.
Litters of babies.
We talk about Octomom, I know. I have a really funny video that someone sent me of Octomom that Jimmy Fallon did. And, so you know that it's just the silliest thing ever. So it's super inappropriate, which is why I love it. So, and the other thing, again, we're talking about risk of falling. Oh my gosh, we got to quit talking about that. So here we are, slips in the shower. It's very interesting to find these pictures too. They weren't just about pregnant people, but they were about old people. So our elderly population, we know this is an issue with as well, and for other reasons too. They, add not being able to see as well, not being able to hear as well, but because the center of gravity is so different. So, and women also get orthostatic hypotension. They stand up too quickly and then they faint. And that's so worrisome for them. So it's very normal to feel dizzy if you get up too quickly, especially in the third trimester. But, when you're pregnant and these things happen to you, they freak you out and they're concerning, so they will call you.
Right.
And I think it's so important to understand that, like when I did triage, and I would say, this is a normal thing, but boy, I bet you were so scared and that's why you came in. So just being able to acknowledge that, I think, is really important. Okay, not falling down the stairs. So what's really important to understand about trauma? We talked about how women have that increase of 30 to 50% of blood volume. Their heart rate increases. So because they're building up all of that blood, they won't change their vital signs until they've lost 30% of their blood volume. That is so freaky to me because it means we are so behind in fluids. So not just IV fluids, that these people need blood products then. Right. So when you see a change in their blood pressures and their heart rate's increasing, their blood pressure is dropping, their respiratory rate is increasing, that's super, super important that you get them to the hospital as soon as you can, in as safe a manner as you can. So.
And I know you talked about this when we first started. You had the increase in heart rate, you had the increase in blood volume, and then as the pregnancy progresses, that blood pressure actually goes down a little bit, and that's a normal.
In the second trimester, yeah. So first trimester, it's normal, which most people don't know what their normal blood pressure is. Second trimester, because of hormones, especially progesterone, what happens is that your blood pressure slightly decreases. Third trimester, back to what it was in the first trimester.
Right. So if we see a pressure of like 110 systolic, that's not super concerning unless we're also seeing all of these other signs. What we're really concerned about is significant or clinical hypotension, which would be, I'm assuming, less than 100 systolic. Or is it less than 90?
I think you can stick with 100 just because just know that that's what you're using for adults.
Right.
For some people, their normal blood pressures are 80/50, but that's not the norm. That's not most of us walking around. So I would say that seems very reasonable to use 100. And we talked about how the uterus is vulnerable to trauma and blunt injuries. And so I think one of the things that always struck me and I've kept in my mind about different in pregnancy and trauma is that 3 things can happen in a pregnant person that would never happen in someone who wasn't pregnant. And that is a ruptured uterus, a placenta abruption, or a dead fetus. And the dead fetus in itself can lead to some interesting things that can then involve to disseminated intravascular coagulation. And part of that has to do with the coagulation factors in pregnancy. And part of it has to do with retained dead tissue in a body. So we see that very infrequently now because we we monitor it, and then we also help people deliver those dead fetuses. So in a motor vehicle crash, the hemorrhages can occur from a variety of things. That this is just a picture of if you're leaning forward, you hit the steering wheel. Your seat belt also can leave lacerations, and if it's not appropriately applied, then it can also cause an abruption. So generally, it's again those abruption signs: abdominal pain, aboard hard uterus, vaginal bleeding, yes or no, but a sustained pain. And then wearing the seatbelt. So we want to make sure people have the shoulder harness is above the fundus of the uterus. I guess it's okay if it squishes her boobs. This is between her breasts, so at least that's helpful, but it's above the fundus. The lap belt goes underneath the fetus. So just like the flight attendants tell you, if you can remember back when you were actually on a flight, that if you put that lap belt low and tight on your lap, so it really does go underneath the fetus, then it's less likely to do any damage to the uterus. There's also issues that can happen with airbag when they deploy. The problem is, you can get facial lacerations and burns from that, but that's still better than having an issue with the steering wheel or the seatbelt. So cardiac arrest in pregnancy, you can have that with a trauma too. Just remember your focus is going to be the same as what it is with other patients. You want to perform CPR and provide transport as soon as possible. The compressions may need to be applied higher on the sternum. So just a little bit higher because the diaphragm is shifting and her heart is actually rotated a little bit on its side and it's moved up in the chest. And you're not going to be thinking that, oh my gosh, her heart's rotated. But what I want you to think about is I need to do left uterine displacement. So one person needs to be shoving that uterus off of the vena cava. And I also need to make sure my hands are just a little bit higher on the sternum. So, her breasts are going to be larger. They're going to fall to the side unless they're fake. Then you just never know what you're going to do with that, right? So put your hands so they're just in the in between where the breasts are normally, and then just move up a little bit higher and you'll be on the heart. You want to use the algorithms for ACLS exactly the same. And defibrillation is the same as you would with anyone. Defibrillation is what saves people. So if you have electrical conduction issues with your heart, defibrillation is what you need. So it doesn't matter that she's pregnant. This is actually from the American Heart Association, and I was so happy to see that in their last, in 2015, when they revised things, they put maternal modifications on here, and then off right here over by Justin's name, perform manual left uterine displacement, displace uterus to the patient's left to relieve aortal cable compression. So some of this has to do with being in-house, so I don't want you to worry about what's a monitor. Don't worry about that. So, but the other things that are on here, if you start an IV, it should be above the diaphragm. I want you to get an IV in this person regardless. So, but generally above the diaphragm is better. The venous return is so decreased because of the size of the uterus that changes the circulation. So, what's the other thing on CPR? Note the drugs are the same too. So that as you assist with an arrest, just remember it doesn't matter. All those drugs still will be given to someone regardless that she is pregnant.
Yeah, there's no, you're not helping the baby if mom is not alive. We have to make sure mom's alive to provide for the baby.
So the best thing I've ever learned about critical care obstetrics is a fetus surrounded by a dead mother does not do well.
Right.
So you have to concentrate on her. Secondary is the fetus, but these things really help the fetus. So this is manual displacement. These are actually pictures from AHA. So they did a really nice job for education with people. So without manual displacement, no venous return. So you can either use, if you are at the head, because it depends on where you can fit yourself. If you're at the patient's head, you can use, you can use your hand to push that. You're really pushing it right off of the vena cava. So you're pushing it from the right to the left. And in this other picture, you're pulling it. So you can pull from the left to the right or vice versa. It depends on what side of the patient you're on, but you're getting that uterus off the vena cava.
And yeah, so just to reiterate, obviously it says it right at the top, during CPR, normally you're going to have, you know, your person at the airway, so a person giving bag valve mask, you're going to have your person doing compressions, and then in our system, as you know, we have a person opposite the person doing compressions. We're going to have that person pull that uterus or push to the side. So we're going to be moving that uterine displacement, left uterine displacement, to get that pressure off the vena cava. And these images are just showing you either pull it towards you or push it away from you. Just make sure that it's out of the way, otherwise blood can't come through that vena cava. And it comes back to that supine hypotension syndrome, which is even worse now because the heart we're beating the heart for them. We really have to do a good job getting that pressure off the vena cava.
And I think, you know, it's handy that you have those two people that are going to do compressions because you do it for 2 minutes. So then you alternate those roles. Yep. Absolutely. So other special considerations, maintaining an open airway, that's true for everyone. This is an okay time to administer high flow oxygen. So when you're doing BLS, ACLS, 100% O2 is great. Ensure adequate oxygen ventilation. Pregnant women are a little more hard to ventilate. Their lungs are a little stiffer. It's really important. You have to use a jaw thrust maneuver in order to open the airway. Women have a lot of edema in their neck during pregnancy. They kind of have baby necks like mine. So it's harder to open their airway. So make sure that you're ventilating them well. And then when you're transporting, then it's important to transport again on her left side. If you're continuing doing chest compressions as you transport, or if you need to do chest compressions while you're transporting, then again, manual displacement of the uterus is essential.
Dodi, do you want to take a quick break and then we'll do?
Yeah.
Cool. So I am going to pause.
So I think we're finally getting into childbirth. You're like, gosh, are we ever going to talk about delivering a baby? Yes, we are. So I'm just going to show you this video and tell you what might happen when there is an emergency and what obstetrics is all about. So this is a couple that have been driving in their car. Now he's telling her what to do too. There's a lot of stuff about that video I like, but I like to take that man and just have a conversation with him. So, but you know what is happening is these people are trying to get to the hospital,
right? And
it's taking them quite a while. Labor is so insidious. You don't know when it starts. You only know when it ends, because that is with the birth. I think what's important to see with this baby too, it's a giant baby. I know it's 10 pounds. It's covered in vernix, and the earlier a baby is, the more vernix that they could have. So and it's that white, cheesy, waxy stuff. Exactly. We like to call it nature's cold cream. And also full of mucousy blood. You know, that's just amniotic fluid. It's part of the capillaries that burst in the cervix, and that is part of that is the bloody show, which is the mucousy bloody stuff. So it is all about body fluids in labor, that is for sure. But bringing that baby up just needs to be dried off, and I don't know if they had an extra towel in the car or not, but and then just pulling aside and waiting for some assistance, or if you know, they could actually just drive themselves if they're close enough to the hospital. So, but that's the kinds of things that you can come upon, absolutely, that people will call you for. I enjoy that video. So, all right, let's see. So, I think what's also important to understand about this is that a lot of your calls that you respond to will be pregnant women who are not in labor. So it's really it's important to understand, Justin, help me with these initials, mechanism of injury.
Yes, yeah, absolutely. So a traumatic injury, or a possible trauma, so like a car accident or a fall or whatever it is, that's going to be your mechanism of injury. And that's quite often a call. The police will call us, or the fire department will call us after a vehicle accident, and they're worried because mom's pregnant.
Right.
Yeah, so the vehicle accident one is really, really common. We'll come and assess people, and we'll ask the questions like, do you feel the baby moving? You know, have you had any blood? Is there anything abnormal? Do you feel like the urge to push? And we'll advise them to go get checked out by someone who can actually look at the baby using,
right.
Yeah. And then bleeding, we get called for bleeding a lot, especially in early pregnancy. Otherwise, we get called when someone starts having contractions. So
funny. Well, contractions are a funny thing because you don't know how long you're going to have them. You don't know if it's really labor or not. So, but it can happen when there's been trauma. So I think the important thing to remember is about this tunnel vision comment here, that you have to really look at the whole picture, not just the fact that she's pregnant, because that freaks everyone out unless they're a labor and delivery person. Everybody else is concerned and worried and freaked out about pregnancy. So just remember that you're going to do your same assessment. Just in addition to that, you have a pregnant person. So don't let the pregnancy trick you into missing other things by developing that tunnel vision. But don't forget about the pregnancy either. I think that's why it's a medic's least favorite call. I think it's just so hard to figure out. So forming a general impression about what's happening: is the patient in active labor? Do I have time to assess her and address other possible life threats? I need to perform a rapid examination. So doing vital signs, really important. You can see the people on the left are working at in a simulation of a trauma situation, but making sure that you're doing the assessment that you would do for someone who is not pregnant, and then adding the pregnancy issues onto it.
Right.
So airway and breathing, life-threatening conditions with airway and breathing are usually not an issue during a birth. A motor vehicle crash, an assault medical condition can cause life threats. And then airway breathing is really important. I think if you remember too, when you're doing an assessment of someone who's pregnant and using ABCDs, so airway, breathing, cardiac, or and then also you can think of the C's as contractions, and then also delivery, so, or displacement. So thinking about those things in your head will really help you. Circulation, I talked about how blood loss after delivery is expected. You can lose up to 500 mils, but you want to also assess in circumstances where you're called for life-threatening bleeding. And that might be vaginal, it might be from somewhere else. And then the transport decision, if you have to figure out where is it the safest to have this baby. And in some places where you are called and you go to assess people, it might not be a safe place, and the ambulance might be a safer place to be. So you just have to figure out where is the safest place that for both mom and baby, and for yourself as well. So, and then if delivery is not imminent, you want to prepare for transport. So our perinatologist that I worked with always said, get the medics to pick them up and drive fast. And I'm like, well, yes, but driving fast isn't always the answer, unless you're Justin, right?
Right.
what did John Ford call that? Right foot. Right foot is his answer for like everything.
Right therapy, yeah, gas therapy, pedal to the metal.
Yep. But I love the right foot. It took me a while to understand what he was trying to tell me. Oh gosh. So rapid transport, people who are bleeding significantly, who have pain, because pain can also signify other things other than labor, are hypertensive, having a seizure, or altered mental status. I think that is true for non-pregnant patients, and just apply it to those who are pregnant as well. So here we finally are getting to some really nitty-gritty about obstetrics. So you want to do your regular history, but you also want an obstetrical and reproductive history. So gravida is the number of pregnancies that she's had. So if this is her very first pregnancy, she is a gravida 1. The para means that how many, the results of the pregnancies. So if this is her second pregnancy, she is now a gravida 2, para 1. So she's had one other, the result of her other pregnancy was a delivery. We also want to look at full-term, preterm abortion or miscarriages in living children. Now, for you transporting someone, that's not as important as for me in the hospital, but it gives you an idea about what the results of her pregnancies were. Are all of her babies preterm? Did she have multiple miscarriages? And how many children does she have? So were the results of some of those pregnancies twins? So it's an interesting history to really gather data about. What's really important is her gravity and what her gestational age is. So figuring out what her due date is. So how far along in the pregnancy is she? So when I remember asking medics, now how you know how far along someone is in their pregnancy? And what's the most common answer that I got, Justin?
Ask them.
Ask them, exactly. So there are going to be some people that don't know what their gestational age is. They haven't had prenatal care. They don't know that they're pregnant. Really, believe it or not, there are people out there who really and truly don't know that they're pregnant. They deliver term babies. Some of them will have a miscarriage, but there's other ways of trying to figure out how far along in that pregnancy that you are, and we'll talk about those in just a minute.
It's like that show MTV had. I didn't know I was pregnant. They have these actors and actresses on there that are like really thin, and you're like,
yeah,
no.
I've heard some good stories, and I have admitted patients to the hospital that just were in denial. So right. It's very, very strong.
Just wanted to talk about gravida and para real fast. I remember it. I always ask these questions on the way into the hospital. So we're transporting a patient. There's no precipitous delivery, and I'm going to get the gravida and the para because I want to be able to report that to the receiving hospital. And I remember it by thinking of para as parent. And I know that's not perfect because you may not have live births, live children still, but how many children do you have? And then how many times have you been pregnant? And then you can ask that question, has there ever been a miscarriage or any other kinds of problems? But that'll get you your parents of children, and then gravida, how many times you've been pregnant.
Yeah, that's a very clever way of figuring it out. People forget too sometimes about like they'll tell me this is my 3rd pregnancy, and I'll look at their prenatal record and I'll say, well, I see this is really your 6th pregnancy. Oh yeah, but I had 3 miscarriages when I was 7 weeks. Those are still pregnancies. But right. I don't want you to have to worry about that because it's not affecting what's happening right now. I think to look at what Justin is saying, the gravida and the parent or the parity is a really clever way of doing it. And we can get really good information that way. The rest of it, we can quiz people about. I've had people not tell me a lot of stuff, and it's not because they don't want to, it's because they just don't think it's relevant. So it's very interesting being Nancy Drew trying to figure out what the heck is going on with someone. That's part of why we like this job, though. So what can be very helpful, though, is previous complications or concerns that someone had with other pregnancies as well as this one. Have you had a cesarean before? Your placenta problems? Have you had high blood pressure? Part of that is just simply doing your history like you would on anyone.
The last term right there, the EDD, I totally forget what that is. Is that the estimated?
It's a big secret.
Wait,
you're not even letting me get to it. It's estimated date of delivery.
Okay, I thought it was like detainment or something.
Oh, well, it used to be confinement.
Confinement.
So it used to be EDC because once people looked pregnant, they were confined to their homes.
Oh, that's what it was about.
Long before we had this plague out and about. So, yeah. So the EDC got changed to EDD, but most people call it a due date.
Got it.
Old people still use EDC, except for me. I'm old and I don't use it. But.
You're so progressive, Dodi.
I'm a progressive old part. So I also forget what sample means too. You just remind people.
Signs, symptoms, allergies to medications you take, past pertinent medical history, last oral intake, or like pees and poops, probably going to be some questions for pregnant patients, and then events leading up to.
Oh, right. Okay. I probably have used that multiple times and just not realized that it was sample, and I always forget what it is. So determining the due date, the frequency of contractions, a history of previous pregnancies and deliveries, the possibility of multiples, and if she's taken any meds, any drugs or any kind of medication. So we'll talk about the frequency of contractions in just a minute. If her water is broken, or it's the stupidest phrase in the world, how do you break water? I don't know. Well, I should know. I live in Wisconsin. We have a lot of water that freezes here, but the people understand that more than they rupture of membranes, which is also a disgusting phrase. Rupture sounds just so bad, but we have a lot of weird words in obstetrics. What can I say? And you also want to know the color of the fluid. Amniotic fluid is almost always clear. It might be a little yellowish tinged or pink tinged, but yellow and green also can indicate meconium. Meconium is poop, so it's baby poop. Tarry, sticky, black. It's the first poop that babies have. So if they poop while they're in the uterus, it can indicate that they've had some incidence of stress. It can also just be physiologic, but it's something that we want to look for because we want the fluid to be clear. But pink tinge can be also from the mucus and the bloody show. So contractions are really so confusing for people to remember how to do and to time them. And it's so simple. Really, you look at when a contraction begins and when the next contraction begins. That is your frequency. So beginning to beginning. The beginning to end is the duration. And honestly, most of us don't really care about that. We want to know frequency. So the intervals, when contractions started, and of course, we always narrow everything down to were the contractions less than 5 minutes apart. And people are like, hey, I've been contracting for days. So oftentimes, really, labor is so hard to put a timeline on. And we expect these women to do that. It's just silly. But when you report to us in the hospital after you transfer someone, really how close their contractions are, that can be really helpful. It can also help you decide if you should transport a patient or if you should stay and make the scene safe so you can plan for a delivery. So it's only one piece of the puzzle though, because contractions are tricky little people. But just remember, beginning of one to the beginning of the next one.
And you'll see it when they start. Like, you don't even have to ask the
Nope.
to tell you. Like, she's like, ah! And you're like, oh,
Yes.
There's the start of a contraction. It is this time. And that's the end of a contraction. And then if they're greater than 5 minutes apart, I would say just go off to the hospital. And if they're really close, like 2 to 3 minutes apart, then it's probably more something you should be prepared for imminent delivery.
Yeah, so use it as part of your whole picture and your common sense and your critical thinking skills. It's just one piece of the puzzle, but it's important that you know how to do it. It's not like we all walk around timing contractions. So I dream about these things, but you people do not. Actually, I don't dream too much about them anymore. I have had very little work dreams since I've retired. They're weird ones though when I have them. So, physical exams, you want to assess the major body systems as you would for anyone, any adult. Emphasis is on the chief complaint. So is the chief complaint, I'm in labor, or is it I have vaginal bleeding, or is it she had a seizure? So really focus on that first and then look at the whole picture. If she's in labor, you want to focus on whether or not you should stay or go. So only look at her perineum if you suspect that the delivery is imminent. So like that video I showed you of the woman in the car who's grunting and you can tell she's pushing, that is a woman you need to look. And the thing about crowning that's really tricky is that the baby might crown and then there's not a contraction and the baby, you can't see the baby anymore. And you think, oh, I can transfer her now. And the next contraction, the baby's out. So labor is just tricky. And I think that's why you need to spend enough time to really evaluate whether or not it's safe enough to go. But don't waste time because you want to get to the hospital if you can. Did you want to say something, Justin?
No, I was just.
Oh, you were like waving your hand at me.
The baby coming out with a contraction and receding without one. It's
really tricky. Yeah, and that baby can have part of its head sticking out for quite a while before it's delivered. And so be ready for that as well. If you're going to stay and deliver, then you still have to be patient. Vital signs, you want to be watching for tachycardia. Often moms in second stage or when they're pushing have tachycardia, you can imagine. Valsalva maneuver, and then you're trying to, you might be panting, you might be, super anxious. So all of that can increase your heart rate. And you don't have to be, if you're going to be delivering a baby, don't worry about taking her blood pressure until afterwards, really and truly. Focus on why you are there. Are you going to boil the water and tear the sheets, or are you going to take some vital signs and transfer her? So I really don't know why we boil water, so don't send anybody off for doing that unless you just want them out of your way. Or make tea for later. So the English people make the tea, so they will put the kettle on. Hypertension can indicate more serious problems as well. So again, if her complaint is a headache and contractions, and she's not imminently going to deliver, then the blood pressure is really an important thing to be assessing. Reassessment, I love this. Childbirth in most cases is a natural process. And obviously, as we saw in the video, it doesn't always require our assistance. So, so silly. But there are things that I'm going to show you that are important for you to do to really protect the baby's head and mom's perineum. So, communication. One of the things I always wished for as a clinical nurse was if I had a heads up that someone was coming in by ambulance, and I loved it when I got that. So what I've asked people in the past to do is if you have someone that's coming in that you're super concerned about and needs to go to labor and delivery, ask the ED to please call labor and delivery when you're calling them. That just, everybody's always ready for whatever that walks in, but it's just an extra friendly thing to do. So I remember one of the last deliveries I did before I left Cottage was a woman who was 32 weeks pregnant who was bleeding in the field. And I knew both the medics that brought her in, and they were fantastic. They had 2 large IVs in place. She was in a semi-Fowler's position, and she had left uterine displacement. And immediately as they walked through the doors and I saw them, they started giving me a report, helped me get her in bed. They were fabulous. And I just felt like I had so much stuff that was already done. And I could just pick right up from where they had really given me some information. Man,
that's great.
It was fabulous. It was such a gift for me to get before leaving too. And that woman had an abruption. We ended up delivering her within the 30 minutes that she got to the hospital, and she got blood too. I think she got like 3 or 4 units of blood. So
Wow.
I just felt like, all in all, she had and she was a nurse. She had incredible care from the get-go. So 4 stages of labor. Everyone tells you there's 3, and they are tricking you. There's 4. So the first stage of labor is when the woman has contractions. So what's happening? She has contractions through all this, but her cervix now is opening. So the cervix is long, thick, and closed during pregnancy in order to protect the fetus. So during the first stage, she could lose her mucus plug. And the mucus plug really and truly looks like snot you would blow out of your nose with blood streaks in it. So, and sometimes people will show it to you and you will be like, oh, this is so gross. Well, it's a body fluid that we're just used to, and it's just part of the process. So just say thank you for showing it to me, and you can discard it. It doesn't necessarily mean anything, but all the books say that if you lose your mucus plug, labor is going to start. So false. But the mucus plug, she might have her bag of water break, and that hopefully you want to find out the color. You're hoping that it's clear. It could be just a trickle. It could be a large amount of fluid. Sometimes the amniotic sac does not break until it is artificially broken before the provider assists with the delivery. If the baby is born in the bag of water, you need to make sure that you do break it so that the baby can breathe now room air, because it's been in an environment where the placenta and the umbilical cord have been assisting with respirations in the respiratory system, and now it needs to breathe 21% oxygen and be in room air. So make sure that you break that bag.
And that's if baby comes out still inside the amniotic sac. Yeah, inside the.
And there's a fancy word for that. Do you know what that is, Justin?
What's that?
When the baby is born in the bag?
I would say it's like a little Nemo situation.
We should call it that. It's called N-call.
N-call.
2 words. 2 words, yeah. C-A-U-L, call. I'm going to quiz you on that the next time I talk to you.
Yeah, just imagine, a fish inside.
I know. It's just one more interesting thing about obstetrics. So the second stage of labor is the pushing part. So that's from the complete dilation to the delivery of the baby. For some people, that's hours long. For some people, it's minutes long. So generally speaking, the more babies you have, the more likely it is for you to have a shorter second stage, but there's nothing written in stone about any of these things. It's a generality for everything. So the third stage, of course, is my favorite, because that's when the placenta is born. So that's from the delivery of the baby to the delivery of the placenta. And generally that happens within 5 to 30 minutes. So unless your protocol dictates you to deliver the placenta, you don't need to. You can transport without worrying about that. We can do that at the hospital. If the placenta tells you it wants to birth, then you should deliver it. And we'll talk about that in just a few minutes. The fourth stage of labor is postpartum. So that's the time when you would do fundal massage, when you would do the vital signs, and you keep the baby warm by placing it skin to skin, as long as it does not as long as it does not require resuscitation and the mother is willing. Sometimes in the deliveries that you're called for, there might be someone that really wasn't sure about the pregnancy. They're just they don't want blood and guts on them, because remember, the baby has vernix and blood and amniotic fluid on it. So dry the baby, that's what's really important. Okay, so we just talked about that. Labor is almost always longer in the first time mom than a multi-gravida. That just means more than one. So she's been pregnant more than one time. And I guess it's unfortunate you're either a first time prima gravida or you're a multi-gravida. So it's okay. Braxton Hicks contractions are those that are called false labor. That one of the things about obstetrics that drives me crazy is there's so many negative terms in it. So false labor, all the contractions are doing something. Braxton Hicks was two physicians that discovered that contractions occurred during pregnancy as the uterus grew, just like all your other muscles contract. So they got to name these contractions that weren't actually labor contractions. So women may call for those, though. They come to the hospital with those because they're unsure. So, and we welcome people who are unsure, because, you know, we want to save you from having to worry about them as well. So, and then some people also might experience a premature rupture of that sac. And that doesn't mean they're in labor. It doesn't mean the baby's coming unless they also are having labor with it. So sometimes people will break their water before they're ever in labor, before they have contractions. And that's called a premature rupture of membranes. It just premature means it happens before a term pregnancy, and then a premature preterm rupture is that's actually when it's before the pregnancy is term or 37 weeks. But it can also just rupture without there being labor. And so for some people, that's why they'll call you. They're, oh my God, my water broke. And they might think that the baby's going to fall out. And without labor, it won't fall out. It's very unlikely. So this is a table that's in your book that really talks about the difference between true and false labor. It's something that we use when we teach childbirth classes. I used the chart like this for 2 decades when I taught childbirth classes. And sometimes this is really helpful and sometimes it's not. People say, oh, you'll know when you're in labor, and that's not necessarily true either. So I think that we just need to pay attention to the fact that when women have contractions and they feel they need assistance getting to the hospital, they're going to call you. So when people are scared, they're so grateful that you were there to answer their call. And there's a lot of things that make people scared, and especially about labor. I wish I could have a nickel for every woman who looked me in the eye and said, I'm really scared right now. So, and that almost inevitably comes before they deliver. So the second stage of labor, we talked about how this is from the complete dilation of the cervix, which you will just have to assume if the baby's crowning, you know for sure that she's in second stage. The uterine contractions usually get a little bit closer together. And I think the reason that you look at someone's perineum, especially when they're grunting, is to look for that perineal bulge. And then also the top of the head, which is called crowning. Because what you're seeing is the crown of the baby's head. And it's also called expulsive or pushing stage. So you might see that written down as well. And like in the video, pushing is involuntary. They just absolutely cannot help but push. I think one of the things that we learn is when we don't want them to push is we say, stop pushing, stop pushing. And the last thing that they hear is what they remember. And that's what they're going to act upon. So if you say, don't push to someone, she's going to push. If you say, breathe with me, it's more likely that she'll help, that she will try to stop that involuntary pushing. So whatever you want her to do is what you want to say to her. Don't use those don't words. Again, that's that negativity, I think, of obstetrics. So the second stage, this wants me to put gloves on, I tell you, and support the perineum here. So the anus gets very dilated. As that head comes through, it pretty much flattens out the rectum. So if there's stool in the rectum, it will come out. So I told you every body fluid is available. So oftentimes women will have stool that comes out when they deliver as well. If there's anything in the rectum, it'll come out. Sometimes they pee as well. Amniotic fluid will come out. And sometimes they'll also be vomiting. So all of these things you just have to be ready for. And that's why I think that personal protective equipment is so important. Now,
have I told you that
yeah.
story, Dodi? I'm sorry, not to digress, but when my wife was in labor at
Oh,
cottage,
dear.
we we went to the hospital, and we had the sweetest nurse ever. So she was just such a doll, and she's talking to my wife. She takes her to the bathroom. She won't let her go in there by herself, just like you were saying. You know, she goes in there with her, and they're just kind of chit-chatting about the pregnancy. And my wife's having irregular contractions. And she's like, well, you know, I'm really thirsty. Can I get something to drink? And the nurse like, here, let's have a little sip of cranberry juice or whatever it was. And don't drink too much. My wife takes one of the little cartons that they have in the hospital, drinks some. She's like, oh, I feel so much better. And then just out of nowhere,
Vomits?
exorcist vomits. Just, like, she's like this close to the nurse and just hits her in the face. And the nurse, such a champ. She's like, it's okay. It's okay. No, this happens all. And she's feeling around trying to find a towel. And I'm like this. I'm like,
right. Oh, dear.
did that really just happen? Yes, it did. So it just super fast.
It does. I had a woman threw grape juice up on me. She just leaned right over the side of the bed and vomited on me. And I had grape juice all the way down the front of my scrubs. And I just was like, I'll be right back. I mean, I had to go change my clothes, you know, mop up the floor. I cannot drink grape juice to this day. That was when I was in Salt Lake, so it was really a long time ago. I mean, those things just happen. I was always grateful for wearing scrubs because I used to tell the students when they worked with us, if you don't have blood or betadine on your scrubs when you leave, you haven't worked hard enough today. So let's get in here. You're not just here to observe.
Right.
You know? So it's a funny place. So here's our third stage. Yay! The delivery of the newborn and then the delivery of the placenta. So the magic thing about the third stage is delivering the placenta, but then this is when the fundal massage is so important. So apparently we're not quite to getting the fundal massage, but the thing about fundal massage, I can't say enough about it because people never do it correctly. And it drives me crazy because if you think of what it is, it's not uterine massage, it's fundal massage. So, but you also don't want to push the uterus out. It would cause a tremendous amount of bleeding for you to take care of if you invert the uterus. So you always want to support the bottom of the uterus with one hand, and I'll show you a picture of that as you massage with the other. And the reason of massaging is to get the uterus to contract again. So it clamps off those blood vessels and limits the amount of blood that is lost. So I will show you that. I thought it was this slide, tricked me. All right, so consider delivery at the scene when delivery is imminent. I don't know, imminent is a tough word. So how about the delivery will occur in a shorter time frame than you could get her safely to the hospital.
Right.
That is the best way of thinking about it. So one of the women I know here in Wisconsin works at a bank my mother used to work bank at. And she told me the story about her fourth delivery during a tremendous snowstorm, which we have at least 2 or 3 of those every winter here. And winter here lasts for like 8 months. So she called the ambulance, and the ambulance came, and they were like, we're so sorry, but it's going to take us a really long time to get to the hospital. There's so much snow and it's crazy. And she was like, oh, no worries, no worries. So the firefighter that showed up to help was her dad. And so her dad was one of the people that delivered her.
Oh my gosh.
I know. So crazy. I just was like, that is just not right.
That's not right.
I know. Inclement weather. So how do we know if delivery is imminent? So what's the behavior I think is the most important? Is she pushing? Does she feel a lot of rectal pressure? Will she not move from where she is? You know, so how long have you been pregnant? when are you due? I mean, these questions are fascinating. So if the delivery is imminent, these are questions you can ask if you have the opportunity to, but you also need to really prepare for the delivery. What baby is this for you is helpful. Is this your first baby? You know, and the contractions, again, how far apart are they? She's going to give you information about that. But again, look at her behavior. Are you bleeding? Has your water broken? Do you feel like you need to have a bowel movement or feel the need to push? Those are the two most important questions that there are really that you need to know whether or not you need to boil water and tear sheets. Tearing the sheets simply means that's how people used to tie off the umbilical cord. So I always say boil the water and tear the sheets. And sometimes people look at me and they're like, I have no idea what you're talking about. So that simply is an old practice before we actually had cord clamps. But if you don't have cord clamps, shoestrings will work as well. So.
All right.
If you have shoestrings.
This is the Bear Grylls edition of pregnancy.
That's right. It's when you have winter that lasts so long. But also looking for potential complications, ask about previous deliveries. Have you had problems in any of your pregnancies? Do you use drugs, drink alcohol? And of course, these are questions if you have time to be asking instead of preparing.
Right.
Is there a chance of multiple delivery? That might be a good question to ask, though. How many babies do you have in that uterus? So does your physician expect complications? I love that one. Well, we'll just take care of them right out here in the field. How's that crap, yeah? And then inspect the vagina. You're not really looking at the vagina. You're looking at the perineum because you're looking at the whole picture to check for crowning. I think that helps people if they understand, really, I'm not looking into someone's vagina. And, you know, you're really looking at their labia and their perineum because that's what gets all distended. So I think it's really important to understand that you're not going to stop labor. So do not let her go to the bathroom is my favorite one. Because that's where you find people. When you have calls and people are in labor, they're in their bathtub, they're in the bathroom, because that's where they feel like they need to be because they feel like they have to poop. Never attempt to hold the patient's legs together. Now, I like to tell people the story of when I was born. I was a Frank Reach. I was my mother's first baby. Frank Reach, I was butt first. I was small, thank goodness. But, and they were waiting for my mother's doctor to come in, and I was coming too quickly. So they held my mother's legs together. So I think it always explains so many things about my brain and how it functions. Because I think I was a little anoxic for a little while. I always used to tell people I could be an anesthesiologist if I hadn't had my mom's legs held together. So, plus it was her 21st birthday. So I tell you, it was quite the party.
Oh boy.
I know. She did like me though. So your emergency vehicle should always be equipped with an emergency OB kit. I think this too is where the whole boil the water, tear the sheets comes from, because if you don't have these things available, still you want to make sure everything is as clean as possible. So use things that are as clean as possible. Some of the places that you are called to may not be very clean. So having that emergency kit and clean blankets will be really helpful to you. You want to do as much as you can to preserve patients' privacy. You have to, though, expose her genitalia. That is where the baby comes from. So that's just something you'll have to do, but you want to preserve as much privacy as possible for her. Clear the room is for as many people. I think what happens is, what I've noted when I get called to the emergency room to assist with deliveries, everybody in the whole planet is in that room because it's so sensational. It's something out of the ordinary. And so everybody comes. And so I remember being down there one time and saying, clear the room, everyone out. The only people I want in here are, the physician and one other person or something. And they'd be like, oh, but the least amount of people that you have helps with her privacy and modesty as much as possible too. You want to put her on a firm surface. I will tell you, I still, when I delivered babies, because the physician wasn't there, I had people on their sides. Again, you're promoting that blood flow and the venous return. It's much more comfortable for her. You have a good visualization of what you need to visualize, and you have room to deliver the shoulder. When a baby delivers, it will automatically rotate unless there's a problem. That anterior shoulder delivers, but you have to then bring the baby downward. And while you do that, you have to have a place for it. And if someone is on their backs with their legs up, you won't have a place to move to bring their shoulders down. So sometimes the babies will just fly out. We don't want them flying out, but sometimes they do. They don't read the book or watch the videos. So you just have to be cognizant of that. You want to support the head, the neck, and the upper back of the baby. The head is enormous in the newborn. It's a third the size of the baby. So, and their necks, they really need a lot of support with that. So, forget that her legs and hips flex, although I'll show you the picture of that and how that might be a benefit. But still, side lying is the most beneficial. So. Place the towels or sheets on the floor, open the OB kit. This all makes sense. But just remember, there's nothing sterile about a delivery. So the picture on the left is the picture that this is how I would have people, she has a pillow between her legs right now because she's pushing. But if you have someone, your partner or your patient's significant other, holding that leg up when she pushes, then you could be on that same side of the body so that when you deliver the head, you have a capability of bringing the shoulder down, the head down when that anterior shoulder delivers. Where on the right side, you can see that there's really no place to bring the baby downward. So, or the other thing is you could put something underneath her hips so that you have a little bit, like this much room, so you could bring the shoulder down.
Elevate her up a little bit, right?
Yeah, that will be very beneficial as well. I think when people are sitting up like this, though, what happens is the baby is pushed into the sacrum. And so the baby doesn't round the sacrum. They have to come around like this. And it's much more difficult to do this way. But if the baby is coming and that's the position she's in, then just have at it. You'll be fine in this position. So again, you want to support the perineum with one hand. So you have in your OB kit, I think you have like 2 sterile threads. You remember, Justin?
There's a lot, yeah.
Okay.
There's a significant amount.
And if you don't have anything, it's okay. Just use your hands. What you're trying to do is cup your hand around the head and support that head from flying out. The top hand, or this person's left hand, is supporting the head so it doesn't just pop out. Popping out means that the mom is going to have tears around the urethra and the upper part of the labia, and they can really bleed and they're very uncomfortable. So you can prevent those from happening by supporting the head, putting a little downward pressure on it, and then supporting the perineum and allowing the baby to come out.
And we're not pushing on the baby. We're just applying enough pressure that the baby's not going to be pushed, literally.
Really, you don't want it to pop out. You want to prevent that. That's not good for either mom or baby.
Right.
So that's why the ensure controlled delivery of the head is emphasized here. So it's really important too that while you're putting pressure on the perineum, you're not going to poke the baby in the eyes or poke those soft spots called fontanelles. Just be cognizant of that. It's not likely that it will happen, but really think that your goal is to support the perineum and support the head so it doesn't pop out. Probably said that now 5 times, so that should be enough. These are the cardinal movements of labor, and so this is has, I think, a good demonstration, really, C, D, and E, about how the baby delivers. So cardinal movements are a fancy way of saying that the baby is engaged in the pelvis. It's going to C is the extension of the head as it comes between the pubic bone and the sacrum. Then D is as you're supporting the baby's head. So hands on the ears. So when the baby will come out, generally it looks at the floor. So then you want to put your hands on the baby's ears and allow your hands just to rotate the baby this way. Then bring the baby downward, and that will deliver that anterior shoulder. This happens so quickly unless the baby is very large. Once the anterior shoulder delivers down this way, then you bring the baby upward, and that will deliver the posterior shoulder. Sometimes they'll just really and truly just slide right out, and you'll be like, whoa, I didn't even have a chance to do anything. But remember that your job is to support the perineum and support the head, and then guiding the baby out is really what's going to be a benefit. You know, you saw that video, that person had no guidance whatsoever. That baby just came out. So that is a strong possibility that that will be the case for your delivery.
And don't drop them because they're extra slippery.
Yeah, and that's another reason, I think, for keeping them on the side and keeping them on a floor or hard surface is, you know, then they won't have far to fall if they drop, right? But remember that they are very slippery. So don't be afraid to wrap something around them so you don't feel like they're slipping. We talked about this already too. So then the umbilical cord around the neck, you know, that can happen 25% of the time. There is a cord around the neck. So the cord is about the same length as the baby. So it's like 20 inches long. It actually grows in length during pregnancy, something that I, of course, find fascinating. But what you need to do is when you're delivering that, the head, you want to check to see if you can feel an umbilical cord or you can see it. And if you can, what you want to do is bring it up around the head. So it's untangled. If you can't do that, and it's really tight, what you're going to have to do is clamp it and then cut in between those two clamps and unravel it. You have time to do that. So you don't have to do it sloppily. Just get those two cord clamps, and once you have cut the cord, you want to complete the delivery. But you have minutes. You have two minutes or so to do it, so you don't have to rush everything. You have to make sure that you cut in between those clamps. That first delivery I told you about, I didn't do a very good job. I didn't do a good job of clamping the cord, and it sprays blood. And so if it's from the placenta, it's not such a big deal. But if it sprays blood from the baby already doesn't have a huge volume of blood to begin with. So
right.
they only have like 200 cc's of blood. We talked about this too.
So that nuchal cord, while baby's being delivered, the only time we're really concerned about that is we see the head protruding, we notice something around the neck, or they're just stuck there. And then we want to take our gloved hand and make sure that there's nothing wrapped around the neck. And if there is, we want to bring that over the head if possible.
Yes. Sometimes you could deliver the baby by pushing the cord down, but that's just one more complicated thing. So if you think about it in terms of try to loop it over the head, if it's too tight to do that, you have to complete the delivery. So go ahead and clamp the cord and cut it.
And that's the head, that's really when the head is already out. So we have the full visibility of the neck, because once the head is through, the baby can start breathing, and we're not going to be as dependent on that lifeline that is the umbilical cord.
And the umbilical cord is probably squeezed between the vagina wall.
It's not doing a very good job.
Well, so right. It's not perfusing as well. So, and then if the mom is able and willing, you want to place the baby on the abdomen so skin to skin contact can begin. dry the baby, especially the head. And you can cover them both with a blanket, or you can wrap the baby in a blanket, because I'm sure you're going to want to be transported before too long. So before you transport, wrap the baby in blanket. You can actually keep them skin to skin as long as they're covered. Do what is going to keep the baby warm, and what you feel you can see the baby. You have to be able to see while you transport as well. We'll talk about this. So the Apgar score. Oh, I guess we'll talk about that in a minute too. Placenta delivers itself. What are we talking about next? Okay, the placenta. So I told you there were going to be some signs that the placenta tells you, please deliver me before we transport. So what will happen if the placenta wants to deliver is that the umbilical cord will lengthen. And you're like, how am I going to know that? You're going to know that. You'll see more of the cord sitting out by her perineum. There's a gush of blood, and you'd be like, oh gosh, there's bleeding. Well, it's probably the placenta is separating. And then the woman says, oh, I have to push again. So then what you want to do is put gentle traction on the cord. You're not pulling on the cord, you're just making it taut. And the placenta should fall into the vagina and it be expelled. If it's not expelled, you could probably see it at what we call the introitus. I don't know who makes these words up. The entrance into the vagina. And that then you can kind of grab a hold of the edge of it and it will just pull out. So you can't just leave it in there because she'll bleed then. So you'll be thinking, oh, I haven't delivered the placenta, I'm not doing fundal massage, and so her uterus will just fill up with blood and she'll lose more blood. So you don't want that to occur. So if there's not bleeding, you don't see these signs, then just transport her and we can deliver the placenta at the hospital. Here's the placenta again. So this one is implanted. This looks more like a tree. This one is implanted in the center. And you can see how long that umbilical cord is and the Wharton's jelly on it. This is, again, the fetal side. It's the pretty side. Remember to bring it with you if you deliver it. So you can stop or slow the bleeding by kneading the uterus, so doing the fundal massage. So this picture was from your book, and what it's showing, this person's left hand not doing anything. And one of these hands should be supporting the uterus. Now, this is a hospital birth. You can see by the way people are dressed here. And this is often the way physicians will do fundal massage. And I've tried to teach them how to do this, and I finally had to give up. If you don't support the uterus, you really and truly can invert it. And that means it comes out inside out, and all those blood vessels are wide open. So this woman can really use a lot of blood. So instead, what you want to do is one hand goes on top of the uterus, and you'll feel it. It'll be somewhere around the belly button, but you really will feel it. And you want to massage it in a circular manner while the other hand cups the bottom, and you'll feel the bottom of the uterus. So it's right above the pubic bone.
This is the big skill for EMTs as far as OB goes. It's the fundal massage. And in every policy procedure, you're going to see this. So post-birth, the babies come out, the placenta will deliver. You're going to use the fundal massage. And it's really important what you're talking about to not invert that uterus, to make sure that you have that bottom hand on there and you're providing that kind of upward pressure. This person's gloved left hand is providing upward pressure while they find the top of the uterus and they find the fundus, and then they're massaging, they're kneading that fundus to limit that bleeding.
Yeah, so I found this little video. It's a mannequin, not a real person, but I thought it was super helpful. So cup the bottom of the uterus. There you go. Mm-hmm.
And they're finding that fundus by pushing down the belly and finding that hard spot, the top hand. So she found the top of it, and now massaging that fundus in that circular motion, wax on, wax off.
expect it to. You will feel it contract, absolutely. So I guess we have to document too, don't we? It's so crazy. The following, your book tells you emergency situations, more than 30 minutes elapse and the placenta is not delivered. I don't know that you have to wait all that time for the placenta to come. So if the placenta is not coming, then transport. There's more than 500 mils of bleeding before delivery of the placenta. That would be concerning to me, absolutely. And there's significant bleeding after the delivery of the placenta. So those are more emergent situations, and you actually might need another ambulance to transport the baby. So because you'd be wanting to take care of the bleeding with the mother.
I have a question for you, Dodi.
Yeah.
I don't keep a graduated beaker on me with markings for how much blood is lost. How can I easily remember what 500 ml blood looks like?
What it looks like? You can save all the, you can weigh it. So 1 gram is 1 mil.
I'm not going to weigh it. Is there like?
Bring it with you so I can weigh it.
Yeah. Done. I'll bring it. How about those blue chucks? Is there like an amount they absorb?
Oh my gosh, there is, but I don't remember what it is.
So in the OB kit, the blue chuck with the white top, the absorbent pad, takes approximately 500 ml blood or fluid before it seeps over the side. So if you have more, then if you've soaked through that whole pad and it's now running off to the sides, that's a significant amount of blood, which is how I remember it.
It's a little tricky too because there's also amniotic fluid.
Right.
So that is just, yeah, it's tricky. But that's a good thing to keep in the back of your mind, absolutely. I used to know how much everything held, but I got other stuff I'm remembering now. How to make vegetable soup. So.
Oh, Elf on the neonate unit.
Aren't they great? It's kind of hard to bag when you're that little, but I love this picture, and I always just use it for neonatal resuscitation, so I thought, why not? I'll put it in here. So what's important to understand is to follow standard precautions, of course. Gloves before you wear a newborn. We wear gloves for everything, for God's sake. And generally speaking, after delivery, babies start breathing right away. They'll cry, their color will change, and their heart rate, we want their heart rate to be at least 100. I know your book says 120, that's even better. But what we use for neonatal resuscitation is 100 beats per minute. So if babies don't begin breathing, you want to rub their back, flick their feet, and just really try to get them to take a big breath and cry. And you always, again, you're looking at breathing for a newborn before you ever worry about the heart rate. So always do bag mask ventilation before you do chest compressions, always on a newborn. So oftentimes if you give a baby a couple of breaths with a bag mask ventilation, their heart rate will come up, they'll start crying. So that is an important skill to know too, is bag mask ventilation. So positive pressure ventilation. So you also suctioning. Suctioning is another thing that's been like a bugaboo too. We always talked about suctioning infants. And there's some dangers in suctioning as well. So use that bulb syringe as appropriate. You always want to suction mouth before nose, and only do it if you see a lot of mucus, a lot of amniotic fluid, and that you really need to clear the airway before the baby takes a breath. I've been on way too many births where someone has like stopped everything to suction, and it's not necessary in most deliveries. If you can't find the bulb syringe, it's not working, just take a piece of gauze, a 4x4, take a blanket, whatever. You can just wipe out the mouth as well as necessary. Not every baby requires that as well. They might sound a little gurgly to start with, and remember where they were living. They were in that fluid. And as they cry and cough, they will clear their airway themselves. Sometimes suctioning babies will cause them to have bradycardia. You can also cause damage by, because you're so worked up and have a lot of adrenaline, and you can actually damage their palate or the inside of their mouth by using that bulb syringe. So just use it as you need to. Resuscitation, again, the warmth drive. This is from your book as well. A baby that's not breathing, it's important that you open the airway. These are babies that you may need to suction. Stimulate, don't spend a lot of time doing it. Go to bag mask ventilation. That is the ticket to getting a baby to breathe. So if a baby is in what we call secondary apnea, nothing is going to stimulate them. You'll just waste time. So just go to bag mask ventilation and you'll be surprised at how well that it works. So, but you always want to do that before you ever would start those chest compressions. We talked about that too, the M before N. So, so to evaluate the heart rate, you can feel the umbilical cord. The brachial artery isn't as helpful in a newborn as it is in a pediatric patient, but you can use that if you are, if you just don't feel like you want to touch the umbilical cord. But the cord pulsates for quite some time, and it will pulsate with the heart rate. You can also listen to, believe it or not, you can listen to the heart rate with using a stethoscope. So in a brand new baby, you often can see the heart rate. You can see the heart beating. So you can sometimes put your hand on the heart and feel it, but again, use the appropriate techniques for finding the heart rate. So additional resuscitative efforts, if you look at, so you've done bag mask ventilation for 30 seconds, you're assessing the heart rate now, and the heart rate is less than 60 beats per minute. This means that you need to do chest compressions. So, and you will do breathing and the chest compressions together. So it's, but it's essential again that you understand too how to do chest compressions in a newborn. And there's a picture of that coming up. I always think that the next picture is what I want. So, but if chest compressions are required, you want to use the 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. So someone's going to count out those chest compressions, and you want to use your thumbs encircling the infant. And that picture is coming up. I hope it's the next one. Yay! So no longer do we recommend using the 2-finger technique. So you want to use your thumbs. You're not squeezing the baby, but you're stabilizing the baby by having your fingers below the baby and then your thumbs on top of each other, mid-sternum, and you are, or mid-nipple.
Yeah, that's what I was trying to show with this, where my fingers down here aren't moving. They're just holding baby.
Right.
My thumbs are pushing the sternum.
Right.
So I'm not using these to squeeze.
You're not squeezing, yeah.
Just the thumbs.
But you get it's a much better technique, and you get better chest compressions than you do using 2 fingers. So the science that we discover every time, really, they publish guidelines, and then the next 5 years they're studying them to see how they work, and then they make those revisions based on the science. So, and meconium, if you see meconium in the amniotic fluid, then you want to suction that before you provide rescue ventilations. You don't want to push the meconium down into the trachea. So that would be somebody that I would want to suction, is that those that have meconium. So the APGAR score, you know, when I ask medics about this, they tell me, oh, this is what I'm evaluating: appearance, pulse, grimace, activity, and respirations. And I'm like, yeah, but what does that mean? So you don't have to, it's not that you just know what the values are. You have to also know what is it that you're evaluating. But where did the APGAR score come from? It's another thing that I love. It's, you know, my Virginia, she is quite the woman. So Virginia APGAR was a physician. She was a surgeon originally in the 1930s and 40s. And that's when the new specialty of anesthesia came to be. And her colleague said to her, you know, Virginia, you're not going to make it in surgery. Women just aren't surgeons. So there's this new subculture or subspecialty called anesthesia. And so she became a prominent anesthesiologist in the obstetrical world, teaching nurses how to resuscitate these babies that were, you know, born under general anesthesia, who were born under twilight sleep. And so they really were babies that were very sedated when they were born. So almost all of them required something. Super duper remarkable woman, and she is right up there with Florence Nightingale for me. There she is, my Virginia. So what we do, you know, when she came up with this score, it was just clever that she could use her name. But it's done at 1 minute. It's not done at delivery. You need to do some things to assure your baby is transitioning to life outside of the uterus in that first minute. Then you make a score. How well did I do? How well did I assist this baby transition? Then you do it again at 5 minutes. How well is this baby doing? If the baby's not doing well, you do it every 5 minutes until you have a score of at least 7. So, and as we go through what is the APGAR scoring, you might want to just really and truly have a copy of this. Take a picture of it and keep it on your phone, because it's not something that you're going to remember. You'll do far and few deliveries to remember it. So, but really what you're aiming for is baby gets all 2s. It's very unlikely that this baby is going to be completely pink. They have acrocyanosis, where their hands and feet remain blue for quite some time. They're transitioning from fetal circulation to a newborn circulation, and that takes them a while. So the more they cry, the faster that circulation will change.
A crying baby is a happy baby.
It's so crazy, isn't it? We do like them to be crying, unless you're on an airplane, and then you don't want a crying baby. Unless they just delivered, right?
Right.
I always sit by the babies. So stimulation, we talked about this too. Okay, we talked about this. Sorry, I get ahead of myself. Okay, everyone take a breath. I'm gonna talk about a breech presentation now, so.
Oh, scaring me.
I know. All right, so who delivers breech babies? Medics. So that's why I think it's important that you understand this. We do very few breech deliveries in the hospital, which is really unfortunate. People just don't know how to do them anymore. Midwives in England do breech deliveries. They deliver most of the babies too. So, but breech presentation is complex because the largest part of the baby delivers last. So that, and if the head is in the vagina and the rest of the body is out, the baby wants to breathe, and it's not necessarily able to breathe. So a breech delivery, it's really important that you just continue it and complete it, and not have a literal hang up of the head. So I think that your book says there are 3 types of breeches, and actually there are 4. So there is, the baby that's pictured here is a complete breech. So you won't know that this baby is breech unless a leg comes out or a foot comes out. It's unlikely it would be the butt though. In a frank breech, the legs are straight up. So it looks like a baby that is doing a dive. It's in the midst of doing a dive. So the legs are straight up. Frank breech is that's a frank breech. Then there's a single footling breech where one leg is out, or a limb presentation, or a double footling breech. So if those people appear in the hospital, they go to the operating room. But as far as I know, an ambulance does not have an operating room.
We do not.
And you do not have scalpel privileges. You carry a knife though.
We
Don't
have that one scalpel in the OB for cutting the cord. That's it. And they make it very clear, and I want to make it very clear that the only thing you're allowed to cut with that scalpel is the cord.
Don't cut yourself either. So speaking of which, when you do cut the cord with that scalpel, what's important is if when you slide that scalpel underneath the cord, slide it so the sharp end is coming towards you. So you're not going to accidentally cut the baby. And again, it's that adrenaline. So I don't, personally, I wouldn't care if you even cut the cord. You know, it's just, if you're trying to separate them, then you're going to have to cut it. So just be super cautious of that, because just like that first delivery I told you I did, you know, it's the adrenaline is just so crazy, and it's something that you're doing infrequently. So this is just a picture of the breeches. So the first one, like I said, the pike presentation with that's the frank breech. So it's the buttocks, the legs are up. That is the easiest delivery to do vaginally. So that's the one that we're trying to, in the world of obstetrics, trying to teach residents and midwives how to do this delivery, so we have fewer C-sections. The next one is, I think, supposed to be a complete breech. Usually they tailor sit in the uterus, and tailor sitting is sitting, so inappropriate now to use these words, Indian style sitting in the pelvis. I'm part Native American, so I can say that. Then we have double footling, and then we have single footling. And you can see why that single footling breech is really not deliverable. Sometimes we also have a transfer slide where the baby lays crosswise and an arm might prolapse. Those are not deliverable vaginally. Those, you want to cover up that arm and transport that patient as soon as possible. So the breeches usually do take longer. Once that baby comes out, though, more likely it will be a preterm baby, because breech presentations are common during pregnancy until babies are around 30, 31 weeks of gestation. So
that's when they efface, right? Is that the term? When the baby turns, effacement?
No, effacement is the thinning out of the cervix.
Okay.
Are you thinking about aversion?
Maybe.
So there is a procedure that can be done by physicians called an external version.
When they push.
So yeah, so close to term, from the outside, they actually turn the baby. So they make the baby either somersault or do a backflip. Usually it's easier to somersault. It's pretty slick procedure. But we do it in the hospital with an IV, with medication that will relax the uterus, and done under ultrasound. I haven't thought about aversion for a long time. Thanks for asking about it. So preparing is the same. And again, I would say you would want this woman to be sidelined. Sometimes it's really nice if she's able to have her be in a hands and knees presentation. And I know that sounds really crazy, but I think it would be beneficial if more people delivered that way. Again, you have a lot of room, you have good exposure to everything you don't really want to see, but that you need to see in order to do a delivery. So, and this way the baby can actually hang down somewhat, because you have to have a lot more room to hang a body down than just a head. So, and I have a video about that too. So you'll see a frank breech delivery that I think will help you tremendously. So you want to allow the buttocks and the legs to deliver by themselves. You want to just support them. When I've seen breech deliveries in the hospital, I've heard the physicians kind of talking to themselves. It's like, keep your hands off, keep your hands off. Because you want to grab it, and it doesn't need to be grabbed. It just needs to be supported and allowed to deliver spontaneously. The head's almost always face down, so you want to allow that to deliver spontaneously as well. Now again, the shoulders will have to be rotated, and that video will show you how that happens. Now there's this piece in here that all medics learn about making a V with your gloved hands. And I think if you just complete the delivery, you won't have to worry about this. So there's a couple things that you can do to cover up the baby to keep it from being slippery and also warm. But then you want to make sure that you flex the baby's head. And that, again, that video will show you. If you put the baby over your forearm and you put your finger in the baby's mouth, you can tuck the chin on the chest and then deliver the head. Justin, are you delivering a baby there?
I'm not.
You want to be though, don't you? All right, so I'll show you this video, what I just talked you through. Can you hear him, Justin?
No, I can't hear him this time. But this is the breech
that
delivery.
you can't hear him because he's got a British accent. So you can see that there is a butt sticking out there in this mannequin. So this is a frank breech. Keep your hands off. He's not wearing gloves either. We won't tell anyone. And let him come out at least to the belly button. The legs you can help come down just by flexing them. One at a time you bring down. Just let it hang. Bring the other one. And then grab a hold of the baby's hips. So on the sacrum, not on this belly, but on the bones. Yep. And then she'll keep pushing. Yep. And then you can just turn the baby sideways to deliver the arm.
Get that shoulder out.
Yep. If you get the baby out that far so you can see the arm, flex it out so you don't break it. You want to be really cautious about that. Grab the hips and rotate again. Grab a hold of that arm. Now see how the baby's just hanging by the neck. He's just supporting it, and he's going to put that baby right on his arm. You're going to put your finger in the baby's mouth and just tuck the chin down on the chest. He's telling about the cheeks. I'm afraid you'll poke the baby's eyes. So finger in the mouth, chin down on the chest.
Keep it flexed. Chin
Yep.
down.
That fetal position. Yep. And then bring it upward and the head will come out. Just slick. And I know it's like, oh my God, there's no way I can ever do that. But really and truly, you can safely do the delivery that way. And you can also have your partner wrap the baby in a blanket and just hold the baby up for you. And then you won't feel like you're trying to do 12 different things with only 2 hands. But if you put the baby on your arm, put your finger in the baby's mouth to flex the head on the chin, and then your other hand, actually, if you put your bird finger, your middle finger on the baby's the back of the head on the occiput, that will help you bring the baby this way and then up. So it's a really great skill to practice on a mannequin, because I guarantee that you will have a baby that you deliver in your lifetime of being a medic that will be breached. And you will know how to do it.
And I'll make sure when we do skills that we do the breech style delivery with ensuring that the chin stays flexed.
Yeah. Oh, shoot.
Oh, now you done it.
I did. Shoot.
It'll be the present me.
Oh, shoot. Yes. Oh, God, what do I do without you? Ta-da! So, and this is doing exactly what he did on the video. So baby's on the forearm, chin in the finger in the mouth, and then the middle finger is on the occiput. Don't worry about the assistant here. That's a technique that we would use in the hospital, but that just takes some training as well. So I just want you to be cautious about that. So this is a limb presentation or a single footling breech. Now, you know, we don't have x-ray vision, so we can't see inside of the uterus, but if only one leg is out, you can be guaranteed that you have either a single footling breech or a double footling, and the other foot is in the vagina. So, but they can present this way. Don't try to deliver this baby, just try to transport. Take as much pressure off of the limb as you can. So sometimes just elevating her hips will be a benefit. You can have her laying on her side, but her hips elevated, that would be helpful as well. But you can cover it also if you have a saline towel. If you don't, just cover it and keep it warm. So the next complication is actually presentation of a prolapsed cord. This is an emergency situation, and what you need to do is take as much pressure off of that umbilical cord as possible. So the best way to do that is by elevating her hips to push. That actually will push the baby up towards the diaphragm and hopefully take pressure off the umbilical
Like putting
cord.
putting the pillow back under the hips.
Yeah. In the hospital, what I do is I would transport this patient in this position to the operating room. So she'd be knee chest position, butt up in the air, because again, you're trying to take pressure off the umbilical cord. The other thing in the hospital that we would do is do a vaginal exam and push up on the baby's head to take pressure off of the umbilical cord. I've been in enough of these that my hand is still cramped from doing that when I think about this.
Oh my gosh.
But it's really hard to transport someone in a knee chest position safely. So by elevating your hips, perhaps by doing this, would be really beneficial to take the pressure off the cord. Now, if the cord is outside of the vagina, what are you going to do with that, Justin?
So we have two options here. We can cover it and keep it warm. So clean, sterile dressing, keep it warm. And I think that's the book answer. But I know that it's always going to be problematic, because if you use warm water, that's going to get cold, and the cold is going to spasm on that umbilical cord. So your other option, or if you use dry, it's still going to get cold. Your other option would be to one time just replace it back inside the vagina.
Yeah, and that is, so frowned upon with your protocols, but you just really don't have a guarantee as to how long you might keep that warm. So the transporting here is what's so important. Oftentimes a prolapsed umbilical cord comes with a breech presentation. There's just a lot more room as the cervix opens, and the cervix doesn't have to be open very far. Probably my most memorable prolapse cord was a 25-weeker we had on our antepartum unit, and her cervix was open the size of a dime.
Oh my gosh.
So it was like 1 centimeter, and the cord fell through when she got up to the bathroom. So, and we managed to put that's probably when my hand is hurting right now from thinking about that, from the cramping, but just elevating the presenting part. And I actually think it was a foot, and taking her back to the operating room and getting ready. I think it was probably 6 minutes to delivery, but she also was wearing street clothes, by the way. So we were like, okay, you're going to the operating room in your shirt.
Yeah.
There's worse things that have happened. So some of the things you might see in the field when you do a delivery, spina bifida, which is a defect in the spinal cord. What's important is they get covered with a sterile dressing. Moist dressing is better. It's the meninges that are showing, and you want to prevent an infection. They absolutely, I've seen them burst in a delivery when they're unknown. Most women, when they have prenatal care, I won't say most women, women who have prenatal care with ultrasound, who have, and genetic testing, actually will know that they have a baby with a spina bifida. So they are most often delivered by cesarean to protect that spina bifida. The baby is immediately cared for by a neonatologist and a surgeon, and actually within a few hours of birth, hopefully they've gone for a surgical repair. So depending upon the size of the spina bifida. So, but you might see something like that. So there's an occulta, which might be a tuft of hair. or a small indentation, or you actually might see the meninges. So I've not seen very many of these actually. Women take folic acid during their pregnancy, and that helps with neural tube defects, which is one of the things that this is classified as. Multiple gestation, twins occur once in every 30 births. That seems odd, but there are a lot of twins. Twins can come very close together. They can be hours apart. One of my friends had babies that are twins that have birthdays on different days and different months. So she has a September 30th and October 1st birthday.
Oh my gosh. Because it was
I know, isn't that crazy?
Yeah.
I know. And they're a girl and a boy too. So I also think that's interesting. But so twins, the asking of how many babies do you have is really beneficial. But twins often are not head first. They're often breech, or head first breech. So oftentimes, most of the times they are delivered by cesarean. Have to be head first to deliver vaginally. Preterm births, your book says that preterm babies are 36 weeks. It's actually 37. So we look at 36 and 6. It used to be 36. And I'm telling you, with all the other stuff going on in the world, we sat down and said, look, we're going to define the term pregnancy. So, and again, the 8 months, if you want to look at pregnancy in months, that's fine. But again, pregnancy really is 9.5 months. Babies weighing 5 pounds or more is an old part of the term, because we can have term babies that are that size as well, that may be intrauterine growth restricted. But I think for test taking purposes, 8 months, 5 pounds is fine. So now that I just totally confused you, right?
Yeah.
I love this picture. Preterm babies require special care and especially warmth. So putting them skin to skin when you're able to do so is really important. Putting a hat on them too, covering their head. One of my goals before I left was to get all the ambulances a hat, and I never did get around to that. So post-term babies, their pregnancies that last more than 42 weeks. They can be large. They have a decreased amount of amniotic fluid, and they often are more likely to have meconium. They have more, because they're bigger in size, they can have a more likelihood of injury. They're more likely to be born by cesarean, which you're not doing in the field. And they're more likely for mom to have perineal tears, so tears to the perineum, or an infection as well. So, but they're more likely to have meconium. That's probably the biggest thing. A demise, you might have someone who's passing tissue or blood or some foul smelling something that they're called about, some discharge, and they could have a demise. I think if this is true for women who don't have prenatal care, really with prenatal care, there's so many ultrasounds that are done, and when patients complain of not having the normal kind of fetal activity, to have an ultrasound done. So we do a lot more diagnosing of fetal demises than we've done before. But absolutely, you may see this if people have not had prenatal care, or they have had what we call a missed AB or missed abortion. So not all the products of conceptions have delivered. This makes me laugh because every delivery, nothing sterile about anything that we're working with. So again, you want to keep things as clean as possible. And please bring the placenta. Take a picture of it for me. Just bring the placenta with you if it delivers. So. Bleeding, massage the uterus, cover the vagina with the sterile pad. There's a pad in your kit. And if you need to give her oxygen because her O2 sats are low, then do that. People don't need to have oxygen just because. I think we've really learned that that's just silliness. You know that women clot more. They may throw an embolus. So they could have a pulmonary embolus that occurs if they have other complications. But when people have difficulty breathing or they're short of breath, that's one of the things that's really something that we think about as an embolus. Okay, so what should we do with the review?
It's totally up to you. If you guys, if you're cool walking through it with me, I'll run right through it.
Okay.
So let's test my knowledge, Jody, and we'll see how I did. The first labor ends when the presenting part of the baby is visible, contractions are less than 10 minutes apart, the mother experiences her first contraction, the amniotic sac ruptures, and labor pains begin. So the first stage of labor was when contractions started.
Until when?
Until. I would say it's probably the presenting part of the baby is visible.
That is the right answer on here.
Okay.
Now, the right answer for me as a nurse is when the cervix is 10 centimeters.
Okay.
But you don't know that.
I'm not going to check.
May as well, yes. Yeah. So yes, A. Oh, sorry, I'm driving. So, and that, see that this is what this says. You can't assess it in the field. So, when it's crowning, that's friendly enough. Then it goes through all that stuff. So, whoops. Okay.
23-year-old woman who is 24 weeks pregnant with her first baby complains of edema to her hands, a headache, and visual disturbances. Uh-oh, so she might be preeclamptic.
She might be.
That's her vital signs. You know her blood pressure is 160/94. Which is she most likely experiencing? Pre-eclampsia, because eclampsia is seizures. So she's having the before seizures.
Right. Good grief, there's a lot of explanations. It's friendly.
We can see it.
What?
Sorry.
Oh.
2 meetings at once.
Oh, I won't tell anyone. Okay, you're transporting a patient who's 8 months pregnant. How are you going to prevent her from having supine hypotension?
Right lateral recumbent, left lateral recumbent. Oh,
yes.
Multiple places.
But you could also do right if, you know, you just
But
want to avoid supine.
I'd prefer on her left side.
Yes. So you can see her too. Whoops. Yeah.
Immediately after delivery of the infant's head, you should suction the baby's mouth and nose, suction the baby's nose and mouth, assess the baby's breathing effort and skin color, check the position of the umbilical cord. So you've already delivered the infant's head. So we're not going to need to suction right yet. We're going to need to check the umbilical cord.
Now, that would be my answer. Now, they might say suction.
Because well, if we're right there, you know, it's easy to suction the mouth.
Oh, no, yay, it says check for the cord. Yeah.
Yes!
So, yeah, when the head comes out, you want to check and look for and feel for a nuchal cord. And you know it's prominent 25% of the time. Okay.
On delivery of the baby's head, you note that the umbilical cord is wrapped around the neck. You should immediately clamp the cord, make one attempt to slide. Yes. Keep the cord moist and transport. Give the mother high flow. So we should make an attempt to slide it over the head.
Yes.
The need for an extent of newborn resuscitation is based on the 1-minute APGAR score, the gestational age of the newborn, newborn's response to oxygen, respiratory effort, heart rate, and color. It's going to be D.
Good job.
APGAR is going to give us a number associated with that, but we're basing it off the patient.
Yes.
The 1-minute APGAR score of a newborn reveals that the baby has a heart rate of 90, so less than 100, a pink body but blue hands and feet, rapid respirations. The baby cries when the soles of the feet are flicked and resists attempts to straighten its legs. You should. Okay. All right. I'm going to do this. Here we go. All right. Appearance is going to be a 1 because we have a pink core and a blue extremity.
Right.
Pulse is less than 100, so we're going to give it a 1. Grimace is going to be a 1 because it's not crying by itself. It's only crying when we right?
Okay.
Activity resists attempts to straighten its legs. So we're going to give it a 1. Is that a 2 or a 1?
I personally would give it a 2, but you know, I don't know what this dealio is. Let's see the rationale.
All right, so we have, let's see, 1 for the heart rate, a 1 for the body, a 1 for the grimace. Activity, we'll say, is a 2. Now we're up to 5. And then respirations are good. They're at a 2, so we're at 7. So I don't have 7 available, so I'm going to go down 1. I'm going to go B6. Oh!
So, let's see, 8, huh? You know what? I think that unless I was there really looking at the baby, when I first was doing this, I got an 8, but I could certainly see what the 6 would be. So, and 7 is actually more correct. So crazy, isn't it? Aren't we funny? All right.
The most effective way to prevent cardiopulmonary arrest in newborn is it's going to be oxygen, right? So we got to keep them warm, we got to give them, and we have to ventilate. So body temperature, slightly hypothermic, no. Ensure adequate oxygenation, ventilation, yes. Start CPR if the heart rate's less than 100, no. So I would say that it's probably going to be C, even though A makes a lot of sense.
Mm-hmm. Yep. Good job. Ventilation, oxygenation. So I know I always used to tell people it's about perfusion and ventilation. So
while assisting a woman in labor, you visualize her vaginal area and you see an arm protruding out of her vagina. She tells you that she feels the urge to push. You should cover the arm, encourage her to keep pushing as you prepare to rapid transport. Insert your gloved hand in the vagina and try to turn the baby. Instruct the mother how to keep pushing and give her high flow oxygen. So we have a breech delivery.
We have a limb.
A limb present.
Yeah.
Okay.
It's an arm.
Okay.
The arm.
I would say that because this is such a difficult delivery, that we're going to encourage her to keep pushing as you prepare for rapid transport.
She has an arm, not a leg.
Okay.
So it's a transfer slide. Do they deliver vaginally ever?
The arm?
Yeah.
Arm? Well, that means the head's right there.
No, just the arm is prolapsed.
Okay. So we should cover and transport?
Yes.
Okay.
Yes. If it was a leg, it'd be a different story.
So don't tell her to push, even though she's going to keep pushing.
Right. Just breathe with her, because you know she'll push if you say don't push.
A newborn.
Oh gosh, here we go with these numbers.
If it is born after 36.6 weeks and before blank weeks. So it's going to be probably looking at these 37 to 42.
Yep. Yay. Whoops. We're either done or I'm stuck. I guess we're done.
Okay. Dodi, anything else to add for these EMTs?
Welcome to the medical world. Thank you for doing a great job. We would be so lost without first responders. I love pregnant people, but one of the best things I ever got to do in my life is to teach medics. And if I wouldn't have taught medics, Justin, I never would have met you.
Oh, I'm so happy. I'm so happy you did.
So thank you so much for this opportunity.
Really incredible.
And for helping all the Zoom.
Thank you so much. There's multiple meetings happening simultaneously, as always. It's funny so because the less I drive places, the more people want me to be places.
Yeah, my sister has the same issue with school. So, all right, go on to your next meeting. I will sign in on the 7th. If anybody has questions, that'd be great.
Thanks so much, Dodi. I really appreciate it.
Oh my gosh, you are so welcome. I'm going to try to get out of this.
Bye.
Bye.